Good morning, colleagues. We will begin today with agenda item 4. I will now make my address. Honorable Ministers, distinguished representatives, Dr. Tedros, WHO Director General, Dr. Susanna Chakap, Deputy Director and Vipro Officer in Charge, representative of United Nations Agency, intergovernmental organization and non-governmental organizations, distinguished colleagues, ladies and gentlemen. I am humbled by your trust and confidence in electing me to chair this 73rd session of the WHO Regional Committee for the Western Pacific. It is my pleasure to welcome you all to the physically and virtually to Manila. I thank for the outgoing chairperson, the Honorable Minister of Health of Tuvalu, another officer of the last session. I will do my best to follow in your footsteps this week and to manage our program well. When people get the right information in a form they understand, from a source they trust, and in a way that captivates authority. Distinguished colleagues, yesterday we heard from the Director General and about the work of WHO in the Western Pacific region under the Regional Director report. We received an update on the COVID-19 situation in the region, workplace culture, and the efforts taken to prevent and respond to sexual exploitation, abuse, and harassment over the past year. I would like to thank WHO for its continuing support as we have shifted our response toward living with and suppressing COVID-19, and for driving forward our share for the future vision simultaneously. On behalf of all member states, we appreciate the work of all WHO personnel in the Western Pacific region, including the efforts you have put in to co-creating a workplace culture that supports you in delivering this work. Colleagues, this year we have 6 major technical agenda items to discuss in the next few days, including communication for health, cervical cancer, mental health, non-communicable disease, prevention and control, primary health care, and reaching the unreached. This is a very full program, and I would like to provide a brief overview of these items. Now in the other, we will consider them this week. The first technical agenda item we will consider this week is a panel discussion on communication for health. Every day, people are exposed to information about health issues on social media and websites, through TV and radio, on posters, and in conversation with colleagues, friends, and family. This information shapes our belief and ultimately the decision and action we take that affect our health for better and for worse. When the people get the right information in a form they understand from the source they trust and in a way that captivate them, it has the power to change hearts, minds, and action, and improve public health. For example, it can prompt people to get vaccinated, lower their alcohol intakes, and change their attitude around mental health. In recognition of the role communication can play in addressing the region health challenges and affirming the position of communication as a technical field requiring specialist expertise. We will hold a panel discussion on this topic. Member states are invited to share their experiences with communication for health and perspectives on actions needed to strengthen its application in the Western Pacific. The second technical agenda item is non-communicable disease. The largest health threat in our region. Many countries in our region are experiencing an increase in NCD and are on track to achieve the SDG targets by 2030. The impact of NCD results throughout society, affecting life expectancy, well-being, sustainable development, and social and economic progress. At the same time, NCD are largely preventable, so if we increase our investment in NCD prevention and control now, we can make a difference in our future and ensure sustainable development in our region. To address the surge in NCD, it is critical that we integrate NCD prevention and control into primary health care, including patient screening and disease management. Furthermore, NCD occur from a combination of genetic, physiological, environmental, and behavioral factors over time. Therefore, cross-sectoral action and coordination among different sectors beyond health is critical to creating health-promoting environments. To support the member states to strengthen their efforts on NCD prevention and control, the Regional Committee is invited to endorse the Regional Action Framework for the Prevention and Control of Non-Communicable Disease. It calls on member states to invest in life-saving and society-transforming measures to combat this epidemic today and create a healthier future. The third technical agenda item is primary health care, which is critical to achieving universal health coverage and strengthening health security. Countries in the region have made a great progress in improving health outcomes for maternal, reproductive, and child health, as well as many communicable diseases. However, the rising burden of NCD and rapidly aging population pose new challenges to the health system and its future sustainability. Further, the COVID-19 pandemic threatened the health gains of the past 2 decades, bringing an urgent need to rebuild health system to be resilient. Addressing these challenges requires comprehensive primary health care, which is integrated, people-centered, equitable, and which promotes health throughout the life course. This will mean adopting innovative approaches in how primary health care is organized, financed, and delivered. The Regional Committee is invited to endorse regional framework on the future of primary health care in the Western Pacific. The fourth technical agenda items is reaching the unreached. Reaching the unreached is a challenge that unites us all. In every country and area across our region, there are still groups our health system and services cannot reach, and who have poor health outcomes. Our region is also facing many challenges, such as climate change, changing demographics, and high rates of migration. This many results in more enriched groups and put those who are already enriched at higher risk. The COVID-19 pandemic brought into focus an importance of health system that can efficiently reach everyone everywhere and maintain delivery of essential health services during health emergency. It also gave us the opportunity to learn just now quickly we can innovate to address critical health system issues. As we work to build back from the pandemic, we have an opportunity to put those who are enriched at the center of our health system transformation efforts. This means creating systems that are truly person-centered, comprehensive, integrated, and capable of engaging communities in co-designing solutions to maximize health across the life's course. The proposed new regional framework has been developed to reflect the diversity of country and area across our region. It emphasizes the importance of health sector action at national, subnational, and local levels and encourage the engagement of multiple stakeholders in pursuit of health for all. The Regional Committee is invited to endorse the regional framework on reaching the unreached in the Western Pacific. The fifth technical agenda item is cervical cancer, a disease that can be eradicated and yet continue to cause suffering and death among women across the region. There is an urgent need to accelerate efforts to meet the global targets for the elimination of cervical cancer. The human papillomavirus vaccine must be included in the national immunization programs to vaccinate 90% of girls before the age of 15 and protect the next generation. Screening services must be expanded to cover 19% of women above the age of 35. An innovative system must be put in place to treat at least 70% of women with cervical cancer. The proposed strategic framework highlights the importance of culture and context-sensitive health communication, service integration, inclusiveness, equity, and trust in the progressive realization of goals and target outcomes. The Regional Committee is invited to endorse the strategic framework for the comprehensive prevention and control of cervical cancer in the Western Pacific region 2023 to 2030. The sixth and final technical agenda item is mental health. Good mental health is integral to everyone's well-being and critical to a well-functioning society, especially during times of crisis or emergency. Unfortunately, current approaches to mental health are leaving too many behind. The Regional Committee is invited, and the burden of poor mental health continue to grow. The wide-ranging impact of the COVID-19 pandemic on everyday life has only amplified these challenges and the unmet mental health needs of everyone. After nearly 3 years of journey, a new regional framework for mental health has been developed to enable the region to address the mental health challenges of today, while anticipating the need of the future. Together, let us refocus the agenda, transform our approach to care, and embed mental health in our communities. Anchored by a shared vision of the highest level of mental health and well-being for all people in the region, the Regional Committee is invited to endorse the Regional Framework for the Future of Mental Health in the Western Pacific 2023 to 2030. Over the coming days, in addition to these important technical agenda items, we will also consider progress reports on critical health issues for our region and a range of other important standing agenda items. This will include the program budget and coordination of the work of the World Health Assembly, the Executive Board, and the Regional Committee. Excellencies, distinguished delegates, thank you again for entrusting me as the chair of this important meeting. I look forward to fruitful discussion this week. Thank you very much. Before we resume the rest of the agenda, draft resolutions have been uploaded on the Regional Committee web portal. If any member state would like to submit an amendment to a particular draft resolution following on our discussion of the agenda item, please submit your suggested amendment by email to the RCM email address. In suggesting an amendment, please use precise language. Before we start, I would like to remind you all to press the button on your microphone if you wish to speak. The list of the speakers is generated in this way because we are also joined by colleagues online. When it's time to deliver your intervention, please wait to speak until the light on your microphone is green. Thank you very much. Now we will resume our consideration on agenda items 6 and 7, addressed by the Director General and report of the Regional Director. As I just explained, if you wish to speak on this item, please click the button on your microphone if you are in the plenary, or by using the raise hand function on Zoom. If you raised your physical or virtual hands yesterday and did not get a chance to speak, please press the button or raise your hand again now. The next speaker is Laupedia, to be followed by Tonga. The floor is yours.
Honorable Presidents, Honorable Ministers, distinguished delegates, ladies and gentlemen. It is a great honor for the Lao delegations to address on health emergencies preparedness and communicable disease controls. Lapidia will sustain and leverage on the investment made during the COVID-19 pandemic to build strong and resilient health systems for the futures by further strengthening core capacities to be prepared for any public health events, whether a new variants or an emerging or novel pathogens. We will strengthen and implement the genomic surveillance systems to guide better public health actions through improving the interconnectedness of clinical, epidemiological, and laboratory formations, including genomic sequencing data, assessing these data and making decisions. COVID-19 have taught us how important it is to strengthen the information sharing mechanisms and between the national and subnational levels. The public health emergency operation centers have served as a platform to facilitate this, including for multi-source surveillance and for the coordinated public health actions within and beyond the health sectors. Moreover, using a multi-sectoral approach, we have reviewed and revised our national health security plans and conducted an interaction review for the COVID-19 response, which has allowed us to identify lessons learned and gaps to improve response and ensure systems will be ready for not just for COVID-19, but also for all the public health emergencies. Laboratory capacities in our country have been strengthened and expanded due to COVID-19 outbreaks. Using these new capacities, all the pathogens such as influenzas and other communicable disease can now be tested at the subnational levels. Many communicable diseases are moving towards target for elimination, such as lymphatic filariasis in the process of external evaluations, malaria by 2030s. For dengue controls, every year the Lao government and Ministry of Health face huge challenge to mobilize external and internal resources to support prevention activities, as well as rapid outbreak response compared to other communicable disease. Our focus is on proactive and sustainable vector and larva management, provision of appropriate clinical management, and ensuring a system in place to rapidly detect and respond to dengue. In closing, we would like to thank WHO's and all the development partners and international organizations for their support provided to combat and control COVID-19, as well as all the communicable disease, including dengue in our country. I do thank you.
Thank you, Lao Pia. Next speaker is Tonga, to be followed by New Zealand. The floor is your Tonga.
Thank you, Honorable Chairman. Honorable Chairman, Honorable Ministers and Head of Delegations, Your Excellency, the Director General of the WHO and your team, ladies and gentlemen. On behalf of His Majesty's Government of Tonga, I wish to firstly acknowledge WHO's leadership during this pandemic. We also acknowledge tremendous support provided by various partners. As a Pacific Island country, Tonga wishes to acknowledge the support provided by the Joint Incident Management Team, with major partners joining as a team and WHO as Secretariat. Tonga had its first community transmission of COVID-19 on 1st of February 2022. This was only 2 weeks after the historical Hunga Tonga, Hunga Hapai volcanic eruption and tsunami that devastated part of the country. So Tonga needed to respond to a dual disaster. As a consequence of the volcanic eruption, our underwater fiber optic cable was completely destroyed, disrupting communication. Internet connection was disrupted, and we were unable to call outer islands, including the most affected Hapai Island group. Satellite phone was the only means of communication. The COVID-19 situation, including travel restrictions, made it extremely challenging to receive overseas support. Despite those challenges, Tonga was able to respond to this dual disaster, remarkably well. Preparedness was the key to this achievement, as alluded to by Director of Pacific Support Office. For the tsunami-affected area, the Tonga Emergency Medical Assistance Team, TMET, established in 2018 with support from WHO, was dispatched within 2 days to provide necessary emergency medical support. For the COVID-19, both the clinical and public health teams were trained and ready with high vaccination coverage, strengthened cold chain and registration system. PCR testing capacity in the lab became available for the first time. Contact tracing, quarantine, and isolation procedures developed, and a COVID treatment health center was established. With this level of preparedness, Tonga managed to tackle COVID-19 with only 12 deaths due to COVID up to today. Honorable Chairman, Tonga would like to highlight the importance of preparedness and readiness to emergencies. This is especially important for the disaster-prone countries because we will experience another dual or triple emergency in the future. In our region, EPSAT 3 has guided us to strengthen preparedness for the emergencies, and we need to continue to build on this. Globally, negotiation is underway to have international instruments to strengthen pandemic prevention, preparedness, and response. And Tonga is happy to contribute from the Pacific's perspective. We look forward for the collaboration with the WHO and partners to strengthen the emergency preparedness and response. Thank you, Honorable Chair.
Thank you, Tonga. The next speaker is New Zealand, to be followed by Mongolia. The floor is yours, New Zealand.
Apologies, Chair. I pushed that by accident. I was just checking if everybody was awake.
Please, the next speaker, Mongolia. The floor is yours, Mongolia.
Mr. Chairperson, Dr. Tedros, the DG, Dr. Jacob, Honorable Ministers of Health, distinguished delegates, and ladies and gentlemen. Mongolia would like to commend the work of the Western Pacific Regional Office and the Regional Director, Dr. Kasai, for the continued guidance and tailored support provided to all member states in this region in the reporting period. As documented in the Regional Director's report, WPR/RC/73/2, our region, a home to 1.9 billion people, maintains the lowest mortality rate from COVID-19 globally. We, the member states of the region, can all be proud of this. The ongoing pandemic response, guided by the regional office, aided by the country and liaison offices throughout the region, have addressed the critical areas the countries and areas had faced, ranging from strengthening the laboratory diagnostic capacity, supply of vaccines, and other life-saving tools to shift the focus on sustained management of COVID-19 by utilizing the tools and knowledge we have garnered in the last 2.5 years while responding to the acute phase of the pandemic. Mr. Chair, from summer to fall months of 2021, Mongolia faced the surges of COVID-19 cases, mainly attributed by the spread of the variants of concern, including the Alpha and the Delta variants. despite the high coverage of primary series of vaccination of the adult population. The surge in cases prompted our health system to stretch its limit and open up additional hospital beds, as well as intermediary facilities where patients were admitted until they were allocated a hospital bed. The healthcare pathway we designed has helped us decrease the number of unnecessary hospitalizations, most importantly resulted in decreases of complicated cases and preventable deaths. Distinguished delegates, health is crucial to sustainable human development, and we must honor our commitment to achieve universal health coverage and building and strengthening resilient healthcare systems. The COVID-19 pandemic has affected the service delivery for people living with chronic diseases. Travel restrictions hindering the access to health facilities, canceled medical appointments, redeployment of essential healthcare workers to the pandemic response, disruptions in essential medical supplies have all challenged the service delivery in my country, negatively affecting the well-being of the people. Based on the lessons learned from the pandemic, Mongolia recognizes the fact that there is a greater need for integrated approach in addressing health and well-being needs of the population and health emergencies simultaneously to safeguard lives and livelihoods. As such, while responding to the ongoing COVID-19 pandemic, my government has simultaneously worked to launch a nationwide health screening program for the population. From the 1st of May of this year, the government commenced an annual national screening program to prevent, early detect, diagnose, and treat common communicable and non-communicable disease based on age, gender, and health risks of the population. The overall aim of the program is to early detect non-communicable and communicable disease among the population and refer them for treatment without any delay. Mr. Chair, concluding the address, Mongolia would like to reiterate its commitment to address health inequality and health-related human rights issues in order to accelerate and sustain the progress we made with regards to the attainment of the United Nations Sustainable Development Goal of ensuring healthy lives and well-being for all under the guidance of the For the Future vision of the Western Pacific region. I thank you for your attention.
Thank you, Mongolia. The next speaker is Micronesia, to be followed by Malaysia. The floor is your Micronesia.
Thank you, Mr. Chair, honorable ministers, Dr. Tetros, officer in charge, Dr. Jacob, ladies and gentlemen. Let me first congratulate you, Chair, and the other office bearers for assuming leadership role during this RCM. My delegation supports you and will work with you during this RCM. We thank the Secretariat for the excellent and comprehensive report. The report contains stories of the COVID-19 pandemic, and rightly so, as this is novel and unprecedented. Our region, and individually in our national capacity, fared quite well during this COVID pandemic, despite the many challenges we had to endure. The FSM acknowledges the many support extended to us from partners and donors, bilaterally and multilaterally. Your support made it possible for us to buy time in our initial response, which then allows us to focus on public health education and preparedness. When the vaccines arrived, thanks to the US government and COVAX for their support, we immediately mobilized our health workers. Like anything else, the initial uptake of the COVID-19 vaccine was slow, and we realized that we needed to also dispel COVID misinformation and disinformation, which significantly undermined our effort. Fast forward, and with all the external support from many of you in this room, and with the great dedication from the local health workers, leadership, civil societies and NGOs, youth groups, we in the FSM have successfully contained the community spread of COVID-19 when it reached our shore. So today, the COVID-19 situation in the FSM is under control. and life has been resumed to normalcy. Our borders are open, and we welcome you back to the FSM. Thank you.
Thank you, Micronesia. The next speaker is Malaysia, to be followed by Vanuatu. The floor is yours, Malaysia.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you, Chair, DG, Deputy DG, ladies and gentlemen. Malaysia wishes to thank DG Tedros for his keynote address and acknowledges his leadership in spearheading WHO in these turbulent times. We also take note of the comprehensive report of the Regional Director of the Western Pacific region. Malaysia applauds WHO for the information document on workplace culture and organizational change in the Wipro region. Malaysia recently established a healthcare work culture improvement task force to ensure a supportive and safe workplace in which we adopted pride, people first, respect, integrity, duty of care, and excellence as our core values. We are all policymakers in healthcare where our duty of care to patients is paramount. It is imperative this duty is extended to all our staff who provide that duty of care by ensuring they are valued and respected, and there is no place for any form of harassment. There must also be rigorous adherence to fairness and due process in any investigation. The pandemic exposed significant gaps in global preparedness for and responding to pandemics. This situation has led to impending negotiations for targeted amendments to the International Health Regulations 2005. Accordingly, Malaysia looks forward to contributing our input to the upcoming working group on amendments to the IHR, which will convene next month. The amendments must be focused on solidarity, transparency, and most crucially, equity. Let's not even pretend that the response to COVID was even remotely equitable, especially by developed countries who largely saved themselves first. We know that health is dependent on many factors outside the ambit of healthcare, and that is where we are reminded of the social determinants of health. We advocate for the shift from a disease-oriented model to a person-centered wellness approach that involves the entire government and society working together, and this is embedded in the Health White Paper for Malaysia Healthcare Reforms. Healthcare cannot succeed in a silo. We must create socioeconomic conditions that will enable people to be healthy, from poverty, education, housing, nutrition, planetary health, and much more. And this call goes hand in hand with our efforts to achieve the SDGs. Malaysia is shifting our focus to intensify NCD prevention. We are facing a double burden of health issues related to the usage of conventional and electronic cigarettes among our population. The government has put forward a new control of tobacco product and smoking bill called the Generational Endgame that will prohibit the sale and usage of all types of smoking products to our generation born from 2007 onwards. Despite the pushback from some lawmakers and the tobacco industry, we are determined that our vision for a tobacco-free generation will not waver. Malaysia is also committed to addressing society's mental health burden. Unfortunately, the lack of awareness and social stigma in mental health and mental illness has prevented affected individuals from coming forward for help, treatment, or intervention. Hence, we recently launched the National Center of Excellence for Mental Health, and this center will integrate public, private, and non-governmental actions to enable the sharing of resources of mental health experts to translate research findings for policy and program development. We must continue to shine a light on this silent epidemic. We are drawn towards transforming our people to become more inclined towards health-seeking behavior. Most people wait until they are very unwell before they actively seek care from the doctor. We need to evolve from sick care to health care and wellness to prevent chronic illnesses from unhealthy lifestyles. Therefore, we believe behavioral science has been an integral part of our region's success story in controlling the pandemic and minimizing the disease burden. Hence, Malaysia is proud to announce that we will propose a resolution on behavioral science for better health at the upcoming 152nd session of the WHO EB in January 2023 and the 76th World Health Assembly in 2023. We call on member states to support this resolution. Finally, Malaysia looks forward to a fruitful deliberation of these next few days as we come together as a region Let us not squander the lessons from the pandemic, which has put health front and center on government's agendas and people's lives. The time for health for all is now. Thank you.
Thank you, Malaysia. The next speaker is Vanuatu, to be followed by Republic of Korea. The floor is yours, Vanuatu.
Director General Dr. Tedros, Chairman of the 73rd RCM, distinguished fellow delegates. Mr. Chair, on behalf of the people and the government of Vanuatu, let me start by congratulating Dr. Tedros and Dr. Kasai for their outstanding leadership and courage during the pandemic crisis. As we know that it is not an easy task, I must also applaud the staff of the WHO back home for outstanding support to ensure that we maintain that level of confidence and trust we have with the people and the government. Stabilizes also the uncertainties of the virus, as well as ease out the biased information regarding vaccines. Chair, we have closed our borders for 2 years and we have fought with our economists because of the economic challenges. But at the end, we won't. We have only 14 deaths. We succeed. Our community transmission period only lasts for 2 months with the Omicron variant. We believe we have few of the lucky countries in the world to experience such a low deaths. But nevertheless, COVID-19 has taught us a lot of great lessons, especially with our health system. However, Vanuatu takes also note of the 5 Bs as mentioned by the Director General Dr. Tedros in his opening address. We indeed we agree that we cannot discount the fact that to achieve universal health coverage, the primary healthcare concept must be factored into our plans. Vanuatu also acknowledges that building relationships with our partners, including WHO and other UN agencies, our traditional partners as TIFAD, MFAT, and China, is critically important to move forward with our health plans. Vanuatu also supports the regional framework, which we will discuss in detail this week. We believe that the framework is conclusive and inclusive already in our health sector strategy and in our new health corporate plan. So we acknowledge WHO for this support. Finally, Chair, allow me please to convey our sincere acknowledgement to WHO for recognizing our efforts to finally confirm yesterday that we have achieved our target to eliminate trachoma in the country. We acknowledge WHO technical support and also the financial support from our partners, for they have stood with us to ensure that this target is achieved. We want to reaffirm our commitment to the public health goals, and we thank WHO and our good partners for the usual support in the coming years. Thank you, Chair.
Thank you, Vanuatu. The next speaker is Republic of Korea, to be followed by Australia. The floor is yours, Republic of Korea.
Thank you, Chair. Okay, it's okay. Thank you, Chair, Director General and Deputy Director General, and distinguished delegates. First of all, I'm pleased to know that according to the report of the Regional Director, we've made progress so far through our strenuous efforts altogether. In particular, it is highly valued that the Western Pacific region has continued to roll out vaccination and maintain the lowest COVID-19 mortality rates. Korea has introduced comprehensive COVID-19 interventions, which are tailored to high-risk groups and vulnerable facilities. In addition, COVID-19 patients are being provided with medical services and more than 10,000 one-stop outpatient treatment centers where patients receive diagnosis, treatment, prescription together as a package. Thanks to these efforts, Korea's COVID mortality rate has been among the lowest in the world, which might be a good example to share with the WPRO member states.
and Korea is willing to share relevant information. However, COVID-19 pandemic is not over yet, as you know, and we need to prepare for future pandemics in parallel. To this end, we have to achieve equitable access to vaccines and therapeutics, which are challenges we are facing currently. Against this backdrop, Korea was designated as a WHO biomanufacturing workforce training hub last February and has conducted training sessions to enhance the capacities of vaccine and pharmaceutical-related workforce from various countries, including those from the Western Pacific region. I would like to request the WHO Geneva as well as WPLO to give a full support for Korea's efforts to strengthen the hub's capacity. In addition, Korea is hosting the World Bio Summit with a theme of Future of Vaccine and Biohealth today. Especially Director General Dr. Tedros is supposed to give an opening speech virtually. I would like to extend my sincere appreciation for his participation and the support to the event. And I would also like to speak about the achievements of the Asia Pacific Parliamentarian Forum on Global Health, which is mentioned in the report of the regional director. The forum was established in 2015 to encourage parliamentarians to share experiences and strengthen cooperation globally. The sixth forum was held in Seoul, Korea, face-to-face last August, for the first time in 3 years after COVID-19 outbreaks, with 14 countries, including WPLO member states. Korea would like to express sincere thanks to WPLO for its support for the success of the forum. Korea will always be committed to practicing Seoul communique adopted at the forum and expect an active role of WHO as the forum's secretariat. Korea would also like to ask our member states to show interest and participate in the next year's forum. Lastly, I would like to emphasize that our commitment to improving the workplace culture within WPLO is more important than ever. For our WPLO staff to fully demonstrate their capabilities, we need to make efforts to develop respectful and inclusive and equal workplace cultures. I believe it will require us to develop a continuous investment and support from the member states of our region. Thank you for your attention.
Thank you, Republic of Korea. The next speaker is Australia, to be followed by Palau. The floor is yours, Australia.
Good afternoon, Honourable Chair, Your Excellencies, Director General Dr. Tedros, and distinguished guests. Australia would like to commend WHO staff across the region for their tireless work and commitment to delivering on our regional priorities and the region's for the future vision. We would also like to show our appreciation to Dr. Susanna Jakob for her flexibility and efforts to ensure WIPRO can continue to carry out core business. We are pleased the region has continued to make significant progress despite ongoing challenges caused by the COVID-19 pandemic. Our agenda for this week provides an opportunity for us to focus on persisting health challenges that lacked the attention they deserved due to the severity of the pandemic, particularly as we transition to living with COVID. This is particularly important to ensure we deliver on the triple billion goals of the 13th General Programme of Work and work towards our goal of health for all. Looking ahead, we know that climate change remains the single greatest threat to the livelihood, security and well-being of Pacific Island countries. We must scale up work in the region to build climate-resilient health systems. Australia is pleased to be developing our own climate change and health strategy, due to be completed in 2023. As a region, there are lessons we must learn from the past 3 years to be better prepared for future health threats. While the region has high COVID vaccine rates for healthcare workers and the elderly, we must continue to improve uptake and access for those who are not fully vaccinated. More broadly, the backslides in immunisation for vaccine-preventable diseases and the increase in zero-dose children is alarming. We see the new international instrument as a vehicle to help support equitable access to countermeasures, including vaccines, and secure more sustainable financing for our regional response. Australia is keen to work with all member states in our region to deliver an effective instrument. The consensus member states achieved on sustainable financing and current work on reform are key enablers towards delivering on our promise to build a strong global health architecture underpinned by an effective and empowered WHO. Lastly, through these times of health crises, our staff are our most important assets. We ask all levels of WHO to prioritise organisational and leadership culture to create a safe and supportive workplace with a positive culture. This will enable staff wellbeing and productivity. A robust, effective and efficient Western Pacific Regional Office is central to delivering strong health outcomes for the region and achieving the goal of making the Western Pacific the world's healthiest and safest region. The office must be underpinned by well-qualified, dedicated and stable leadership. We also remain concerned by the ongoing challenge of mobilising and attracting high-quality staff to country offices and protracted gaps and delays in appointments. We're keen to work with the region to help develop a pipeline of qualified staff to fill key positions at the country level. Thank you.
Thank you, Australia. The next speaker is Palau, to be followed by Cook Island. The floor is your Palau.
Good morning, Honorable Chair, Director General, Deputy Director General, and Regional Officer in Charge, Honorable Ministers, esteemed colleagues and friends, ladies and gentlemen. It is indeed a great pleasure and somewhat of a relief that we are gathered here in person for this regional committee meeting in Manila. It is without doubt that the past 2.5, almost 3 years has been an incredibly difficult and challenging time for all of us, including the Republic of Palau. And while we are still navigating our way through this ongoing and uncertain COVID-19 pandemic, we must now look to maintain balance as we strive to sustain our pandemic response efforts while resuming much of those that have been set aside, including efforts to address pre-existing issues such as non-communicable diseases and the detrimental health impacts of climate change throughout our region. As such, it is imperative that we maintain, if not enhance, our efforts with more determination, resolution, and solidarity, especially as we currently face unprecedented circumstances within the regional administrative structure. Palau nevertheless looks forward to our deliberations this week and appreciate the opportunity to further discuss on regional initiatives and efforts to improve health communication and to address NCDs, including cervical cancer, mental health issues, primary care delivery, and health equity assurance. I would like to extend our sincere appreciation to the Director General, Deputy DG, and Regional OIC. We congratulate the RCM Chair and Secretariat, and finally recognize all the hardworking men and women at our Western Regional Office for their exceptional diligence and engagement with all member states. Thank you.
Thank you, Palau. The next speaker is Cook Island, to be followed by Kiribati. The floor is your Cook Island.
Thank you, Chair. Kia ora ana tātou katoa, te aroa nui o tō tātou atu, ko Yesu Mesia. Warm greetings to you, distinguished delegates from the people and government of our Paradise Islands, Cook Islands. I congratulate you, Chair, Vice Chair, for taking up this important role to support our member states. To the government of Philippines, Director General Dr. Tedros, our recently appointed officer in charge and Secretariat of the 73rd Regional Meeting, the Cook Islands extend to you our appreciation for your leadership in organizing this meeting. And for the past 2 years, we all came through the disruption and major change to our daily lives. Our way of living was turned upside down overnight. We were all affected dramatically by COVID-19. The Cook Islands endorsed the comprehensive report before us, highlighting technical support to the Pacific Island countries in regards to COVID-19, vaccination, support, and response. On that note, Chair, the Cook Islands extend appreciation and affirm once again that our successful response to this pandemic was a collective effort together with you, our donor partners, WHO, UNICEF, SBC, ADB, and others, our neighbor countries, Australia, Japan, China, and many others, and most importantly, New Zealand. Without your helping hands, we wouldn't be able to respond successfully as we did. As Minister for Health, I would also like to sincerely thank the Honourable Minister for Health New Zealand, the Honourable Minister, Tio Aupito, and your government for providing the ongoing support needed by way of supplies, consumables, and technical support in the last 2 years, and going forward for committing to continue New Zealand's support towards the health and well-being of our Pacific people. I am proud to say last week, New Zealand, with the agreement of EU, have now approved for the Cook Islands to apply for digital travel vaccination certificate starting November the 1st of this year. Chair, the Cook Islands successfully vaccinated 98% of its eligible population from 5 years and over. A total of 6,408 people contracted COVID since the 13th of February 2022, with only one COVID-related death recorded. To date, we have no new case in the Cook Islands. As of the end of this month, our current Ministry of Health COVID-19 regulations 2022 will not be extended. We have now normalized across all islands. However, we continue to remain vigilant. Chair, with our success came many challenges, especially to our workforce and systems. I would like to thank, on behalf of our people and government, all our workforce, especially our frontline teams. Acknowledging especially our Secretary of Health, who is here with me, Mr. Bob Williams, his hardworking team at the Maraiora, for taking us through those challenging times. Their sleepless nights, being absent from their families on many occasions, traveling to the islands continuously to deliver services required to mitigate the impact of COVID-19 to our citizens, especially those vulnerable. And through the great leadership of our government, in collaboration with our people, the three pillars of our nation, our traditional, religious, and government leaders, we all embraced each other with the grace and power of our Almighty God as we took our community with us to tackle the impact of this virus. A whole country approach is testament to our success. Chair, since then, we have now redirected our focus towards the real ongoing issues. NCD, mental health, digital health, cancer, to name a few, and the STEPS survey a survey to inform further review for policy directions to our current strategy. I, together with our Secretary of Health, acknowledge the ongoing support towards key projects in the Cook Islands through Dr. Kim Dixon and her team. Thank you again, WHO, for supporting the development and consultation work with our new public health bill, soon to be submitted to my cabinet for consideration. I know our Secretary of Health has kept the regional office very busy, and so we are forever grateful, and we look forward to the continuous support in this space. In moving forward, Chair, we must continue working together in ensuring our Pacific voice is heard. We have identified and voiced similar major health concerns. We must find ways to address them in order to achieve universal health coverage for all. And Director General have highlighted promoting health through educating ourselves and especially our young people at an early age to live healthy, as well as providing and protecting health within our daily lives. These are key areas to progress work on in order to provide a safe and healthy nation for all our people. Me taki Chair, kia ora ana.
Thank you, Cook Island. The next speaker is Kiribati, to be followed by Vietnam. The floor is your Kiribati.
Thank you, Chair. Chairman, WHO Director and Deputy Director General, my fellow honorable ministers, distinguished delegates, ladies and gentlemen. On behalf of the government and the people of my Pacific country of Kiribati, Kamdaben Maori, and greetings to you all. I am pleased to be able to attend this regional committee meeting in person for the first time and to participate in this important event. Kiribati acknowledges the immense support and the work of WHO over the last year, as recognized in the RD report. COVID has indeed placed many challenges on our health system and services across the region. We remain grateful to our partners, Australia, New Zealand, China, Japan, the USA, UNICEF, SPC, ADB, the World Bank, and the COVAX facilities for their financial and technical support, provision of COVID-19 vaccines, equipment, and supplies. Kiribati is faced with a rather unique epidemiological situation. Our geographical remoteness and strict border measures had given us ample time to ramp up the rollout of vaccination, connecting with communities, and the development of SOPs, guidelines, and training materials in line with WHO recommendations to monitor and to manage COVID when it did arrive. The successful collaboration with development and technical partners has helped shape our response and informed many of our decision-making through our Emergency Operations Center. Expert support and the provision of medical supplies, equipment, digital platforms, and state-of-the-art tools from all partners involved have ensured the safety of our healthcare workers and our vulnerable groups. The improvement of quality care, information system, and the expansion of our diagnostic base with long-term impacts. In anticipation of further waves, my ministry will endeavor to put emphasis on booster vaccination strategies and reaching all parts of our country in maintaining high coverage on the primary vaccination series, and to continue enhancing and strengthening the surveillance system and our capacity for case management. To conclude, Mr. Chair, I thank you all and allow me to bestow upon you our traditional Kiribati blessings of Te Maori, Te Roi, or Te Tapamoa. Thank you.
Thank you, Kiripat. The next speaker is Vietnam, to be followed by Solomon Islands. The floor is yours, Vietnam.
Thank you, Chair. Dear Honorable Director General, Deputy Director General, distinguished guests, and country delegation, I would like to commend the Director General, the Regional Office, and the whole of WHO for yet another remarkable year in making the region and the world healthy and safe. Vietnam would like to express our sincere gratitude to the WHO Regional Office for the Western Pacific for the leadership in the COVID-19 response. Throughout the pandemic, the WHO Regional Office and WHO Office in Vietnam have closely guided Vietnam, including the access to and roll out of COVID-19 vaccines, enabling us to attain very high coverage of vaccination throughout the country. The COVID-19 has presented many challenges, but has also opened for us many opportunities to strengthen our public health system, primary health care, regulatory capacity, as well as research and development for vaccines. We are very proud that Vietnam has been included in WHO initiative for technology transfer for the development of mRNA vaccines and therapeutics. We hope that through this initiative, Vietnam will be able to contribute to vaccine security in the future. After 3 years of COVID-19, Vietnam is stronger, emboldened by the resilience we gained during the COVID-19 pandemic, as well as the heightened attention and commitment of our government to health and the development of our people. While we were able to minimize the impact of COVID-19 to the health and economy of our country, we are not complacent. Vietnam has continued to evaluate and review its preparedness and response plan guided by upset, and is now prepared for the sustained management of COVID-19 and other health emergencies. In parallel, we will embark into our plan for recovery and continue to work hard to meet our public health targets in communicable diseases, including ending TB, HIV/AIDS, and eliminating malaria by 2030. We will continue to be guided by the vision for the future to strengthen our system for health security and AMR, to go through the last mile to improve the health of the heart, to rich and vulnerable populations for health, reduce the burden of non-communicable diseases, and prevent and mitigate the impact of climate change. In doing this, we will continue to anchor health in our social development reform and build a stronger system for health in our communities, districts, provinces, and for the entire country, built upon strong governance, community participants, and strong multi-sectoral collaboration. Vietnam will continue to build a healthier and safer future, relying upon the resilience of its people and its long-standing solidarity with WHO. We would like to say that WHO is with our people in sickness and in health. We are sincerely grateful for the efforts of WHO Regional Office, WHO Office in Vietnam, and for each every staff of WHO for their dedicated support to Vietnam. Once again, we commend WHO for its continued commitment to all the member states in the region. In many ways than one, we can all come together to make the Western Pacific the healthiest and safest region. Thank you, Chair.
Thank you, Vietnam. Our chairperson has to attend, to an important matters. I have the privilege to take over, and I will do my best to ensure efficiency in the conduct of the proceedings. Ministers, Excellencies, please be mindful of the time. Stick to the 3 minutes. There are many of us in this room who want to make an intervention, and I can't let you go on over 3 minutes. Don't be sad if I disconnect your microphone. So I have Solomon Islands. Please, you have the floor.
Chair, honorable delegates, let me acknowledge the presence and participation of the Director General to this 73rd Regional Committee meeting. Please allow me to congratulate you on your appointment as the chair of this 73rd Regional Committee. And on the same note, I would like to thank the outgoing chair for his leadership over this 72nd Regional Committee meeting. As I reflect on the Regional Director's address and his report for the year ending June 2022, I see the resilience demonstrated by our region in weathering the storm inflicted upon us by COVID-19 pandemic compared with others. Our region is home to a quarter of world's population, yet we perform comparatively with the lowest mortality rate, as reported. It's indeed a major achievement. I would like to thank the Regional Director, Dr. Takeshi Kasai, and the Western Pacific Regional Office team for your leadership and the support rendered to member states as we join the global effort in fighting COVID-19. Solomon Island is now returning to normalcy, with most of the restrictions lifted, except that non-citizens who wish to enter the country must show proof of vaccination before boarding their flights and or on arrival. The pandemic has taught us important lessons on pandemic preparedness and health systems strengthening. As highlighted in Regional Director's report, the implementation of Asia-Pacific Strategy for Emergency Disease has helped us with the development of a National Health Emergency Response Plan, aligning it with our National Disaster Management Plan well before the pandemic. This has enabled multi-agency collaboration and mobilization of resources to support our frontliners doing border control, quarantine, and testing of suspects. We also developed a COVID-19 specific preparedness and response plan, which guided activity, budgeting, and implementation, since a pandemic of this scale is quite different to managing emergencies that occur on a more regular basis. The negative impact of COVID-19 on our national economy and service delivery has been significant. Public health program implementation declined in 2020 and 2021 due to reallocation of health resources towards COVID-19 preparedness and response, and later as a result of domestic travel restrictions. Measles, mumps, and rubella vaccination coverage has dropped from 99.1% in 2019 to 69.4% in 2021. In response, we had to implement nationwide supplementary immunization activities early this year to scale up our MMR and routine immunization coverage. Other programs that were severely affected by the pandemics are malaria control, TB, leprosy, and NCDs. Compounding all this is increased stockouts of essential drugs and diagnostic supplies, which is partly due to the disruptions in the supply chain and procurement process. In closing, I would like to thank World Health Organization and our donor partners for standing with us throughout the pandemic, and are still doing so as I speak. Unfortunately, time would not allow me to go into details, but suffice to say that support covers personal protection equipment, COVID-19 testings, vaccines, equipment, logistics, emergency medical teams, and technical support for preparedness and response, as well as restoring essential health services support. Besides World Health Organization, I would like to acknowledge the following countries and international organizations for their support. These include Australia, People's Republic of China, New Zealand, United Kingdom, USA, India, Japan, UNICEF, World Bank, and ADB, not mentioning business and other entities who have generously donated valuable items towards our COVID-19 response. Honorable Chair, I thank you.
Thank you, Solomon Island. We'll give the floor to Tuvalu before the coffee break. Be mindful of the 3 minutes. I'm just warning you. Let's hear Tuvalu will be the first country to deliver 3 minutes intervention. Thank you.
Thank you. Thank you, Chair, for the opportunity. Honorable Chairman of the 73 Regional Committee meeting, Director General Dr. Tedros, distinguished delegates and participants here in Manila, and those on virtual mode. Ladies and gentlemen, first and foremost, I must congratulate to you, Chair, for your election as the current Chair for the RCM Committee. Over the last 2 years, COVID-19 had taught us so many lessons. It also tested and pointed out how vulnerable our health systems are. On the 12th of May, 2022, Tuvalu confirmed its first ever COVID-19 border quarantine case. Today, we have a total of 25 confirmed COVID positive cases reaching to our border. All of these cases have been recovered and well contained. At present, Tuvalu still hasn't experienced any community transmission of COVID-19 ever since the inception of the pandemic. We face many health challenges, such as the escalating non-communicable diseases and the various impact it has on our national developments, the posing threat and the health risks of individuals due to the adverse impact of climate change. These are noticeable health challenges, which thus and purely affect the livelihood and well-being of individuals, and thus require urgent attention from us in properly addressing it. Mr. Chairman, I also would like to take this opportunity to sincerely extend our government's sincere gratitude to the World Health Organization, the Secretariat of the Pacific Community, SPC, UNICEF, ADB, World Bank, and the COVAX facility for providing effective support and technical guidance for member states, in this case, particularly for Tuvalu, to be able to respond effectively and efficiently to the COVID-19 pandemic and its uncertainties. I'm also indebted to all our donors and development partners from around the region and around the world for the technical and financial support in terms of human resources, equipment, PPEs, and the provision of vaccines. At the moment, our vaccine coverage sits around 95% of the eligible populations are fully vaccinated, that is from 5 years and above. Without your continued assistance, our country will be overstretching trying to cope with COVID-19 pandemic on top of its existing health issues. I'm also particularly impressed with the strong commitment and work of our government, health professionals at home, and the Tuvalu communities in keeping Tuvalu safe from this unprecedented pandemic. Mr. Chair, I thank you for the opportunity.
Thank you. This is the way. 3 minutes is 3 minutes. Thank you, Tuvalu, for showing Asia Pacific. 3 minutes is 3 minutes. Now let's break for coffee, and we'll be back here in 20 minutes. Thank you.
Even though we are meeting in hybrid setup, it would not be a Wipro meeting with our mobility break. I understand the Wipro dance company will lead the mobility break. So may I ask everyone to please stand up, switch your cameras on and join. For those in the plenary, may we request everyone to maintain safe distance. Please stand up. Thank you very much. The next speaker is Samuel, to be followed by Guam the United States of America. The floor is yours, Samuel.
Thank you, Mr. Chairman. I must say in Samoa, Talofa, Talofa, Talofa lava. Mr. Chairman, Samoa would also like to express sincere congratulations on your appointment as chair for the 73rd session of the Regional Committee for the WHO Western Pacific region. We are sure that your expert and wise guidance will enable fruitful discussions on issues vital to the health and well-being of people of our region. Mr. Chairman, Samoa acknowledges the report of the regional director, which has outlined the areas that have been given priority at this time. Samoa highlights from the report the response to COVID-19 and beyond, which played a crucial role in responding to the pandemic and its challenges. We acknowledge the support by WHO, regional and country officers. We like to highlight from the report the assistance of the COVAX facility through the provision of COVID-19 vaccines, which greatly assisted our country, where Samoa was able to vaccinate more than 90% of its eligible population. Communication for health was of great importance, and this was reflected during the COVID-19 pandemic. Connecting with communities and delivering key health messages assisted in being able to reach the population. The report highlights the health security systems in response to public health emergency and pandemics through the implementation of the international health regulations. Samoa looks forward to the development of a new health security action framework that will address the challenges that countries experienced during the pandemic. NCD remains a burden for Pacific Islands and is a key priority in our region. As noted, 1/4 of NCD deaths occurs in our region and accounts for the majority of deaths. Continuous work is needed in the area of NCDs, where this has gained importance from the highest level of governance as per the UN Political Declaration on the Prevention and Control of Non-Communicable Diseases. Samoa notes the report on cervical cancer and mental health, which has become an important health challenge since the pandemic experience. We look forward to the continuous technical assistance that can be provided in these areas to assist our countries. The issue that continues to face us as a region is climate change. Highlighted in the report is the importance of development of guidelines on climate resilient and sustainable healthcare facilities and infrastructure. This is of great importance in the Pacific region, where we experience sea level rise and changing weather patterns. We acknowledge the comprehensive report and acknowledge the work and commitment of the regional office. Thank you, Mr. Chairman, for our opportunity. Thank you.
Thank you, Samuel. The next speaker is Guam, the United States of America. The floor is yours, Guam.
Thank you. First and foremost, congratulations, Chair and Vice Chair, on your election, Director General, Ministers, and distinguished guests. The United States territories of the American Samoa, Guam, and the Northern Marianas Islands are very appreciative of the support from WHO Pacific Regional Office for their support during the past year. Except for American Samoa, the borders of Guam and the Northern Mariana Islands did not close their borders. Instead, instituted policies of quarantine, isolation, testing, and vaccination that proved to be significant preventive measures in reducing the spread of COVID-19 and saving lives. We are unique in that support from the United States is enormous, and we witnessed during our response that the collaboration of support between the US and WHO both worked in sync to ensure resources are efficiently and effectively utilized. The island territories are unique, and we are so appreciative for including us in the family and support of WHO. The island's health systems are fragile, and containing COVID was a high priority of ours on top of addressing the non-communicable diseases that were prevalent even prior to COVID-19. Providing our health systems with adequate and specific test kits were critical to that mission. Thank you, Mr. Chair.
Thank you, Guam. Are there any more representatives who wish to speak on this topic? Thank you. May I now call on the Director General and the WIPO Secretariat to respond. Dr. General, the floor is yours.
Thank you very much, Chair. I will start with your permission. Excellencies, colleagues, friends, ladies and gentlemen, dear Director General. First of all, it was a very rich discussion, and thank you very much for your comments. It will not be possible to do justice to the richness of the discussion, but we take good note of all the comments that you have made. And in my reply, let me highlight a few issues. First of all, I would like to thank you very much for the support and the nice words for the work of the regional office and the staff. And definitely we will transmit it to the staff, including your appreciation for the timely support that they have provided to your member states when you requested any support from them. Thank you also for your positive feedback and also your support to my work personally as officer in charge. It is a great pleasure for me to be here in this region, as I also mentioned yesterday. It is wonderful to be back to a region after 3 years, but I must say that I really appreciated my work as a Deputy Director General under the leadership of Dr. Tedros, and I appreciate that a lot. But now being back to a region, it is so interesting to link and align the global and the regional priorities. And we can do even more on that front. There were many specific issues that you have raised. And first of all, I'd like to highlight the fact that you all mentioned that WEPRO responded well to the COVID-19. And many of you mentioned that responded better than the other regions. And this was due to the leadership of the regional office and also the leadership at the country level. And that is very much appreciated, and thank you to all of you. The second issue that I would like to highlight, which came up in all the statements that you made, is the importance of universal health coverage and the resilient health systems and the need for strong leadership to invest into this area. Indeed, during the COVID, there was a backsliding on the UHC universal health coverage. You know, our commitment was to reach 1 billion more with universal health coverage, and we managed to reach 300 million only out of the 1 billion. So we have a backsliding of 700 million. And this is why, due to the fact that UHC will remain a high priority and the commitment and target of WHO, the GPW extension for the next 5 years and the 5 priorities that the DG has highlighted yesterday, the 5 Ps, will accelerate the progress towards UHC and towards the other commitments that we have made. On the UHC front, we have to improve the access and coverage to health services, but particularly we have to improve on the financial protection side. And this is why today at the lunch break, we also have a discussion on how we can do that in this region. It is also very important to further improve the resilience of the health systems and reach out to the underserved communities. And in that one, the primary health care will drive the process with the integrated public health functions and the preparedness and response work. Many of you mentioned this. You also mentioned the determinants of health, like the social determinants were clearly spelled out, and also the need for a shift from a disease-based to a health-based approach. And this can only be done if we have a strong primary healthcare system, which focuses on a multi-sectoral approach and a people-based approach. And this is the DG's vision also, as one of his priorities, actually the second priority, as he mentioned in his speech yesterday. I would like to highlight also that in all this work, the UHC and the resilient health systems, primary health care, we need strong country offices in WHO. DG is very much committed to that. This is why during the World Health Assembly, we took a proposal to the World Health Assembly to increase the funding for the country office capacities. We will start in 30 countries as the World Health Assembly has approved it. And then in the next biennium in 24-25, as part of the program budget discussions, we want to roll it out to all the countries where additional country level capacity is required. In this sense, let me also mention that we are moving towards a 3-level HR planning in WHO. Until now, the planning of the human resources was done at a separate level for HQ, for the regional offices, for the country offices. Now, due to the strong leadership and commitment of the Director General, we bring this together to a 3-level HR planning, starting with the country level, building it up to the regional and to the global level, and we do it together for the 3 levels. And that will also help to increase the capacity at the country level. And of course, the rotation and mobility will soon kick in the coming months. In this regard, several countries mentioned initiatives, and I'd like to welcome the G7 leadership of Japan in this regard next year towards universal health coverage and resilient health systems. I would like to thank Korea for organizing the Forum of Parliamentarians, where these issues were discussed at length, and then also thank Korea for his statement today on mentioning the biosafety event that will take place today. And then, of course, our Director General, together with your President and others, will make the keynote speech in the opening remarks. You also mentioned, several of you, the importance of the work on the traditional medicine, which is very relevant for this region, but also very relevant globally. And this is why at the global level, the DG has set up now a new global center on traditional medicine to increase the capacity of the organization to support the countries. Many of you mentioned the digital innovations, and a lot of work is going on this, both in this region and also globally. And we have to align these 2 initiatives, and they are already working together. And this is one of the regions where a lot of innovation work is going ahead anyway. And this will be reviewed at one of the lunchtime discussions the day after tomorrow. Then many other priorities came up, and I want to highlight a few of them. One of them is the importance of the One Health approach. I'd like to inform you that the global strategy to bring the animal health, the human health, and the environmental health together is ready now by the quadripartite collaboration of WHO, FAO, the OIE, the Animal Health Organization, and UNEP, as the environmental protection organization, as WHO is taking the leadership this year as the secretariat of this One Health approach, we are starting to roll out this global strategy now to the regions and to the countries. And it will be a very useful blueprint and roadmap for you also for the design of your One Health approach, which needs a lot of multisectorality. And part of this is also the work on the AMR, which is a big priority for many of you. You also mentioned quite a lot the importance of the infection prevention and control, which came very strongly into the focus during the COVID. And for the first time this year in the EV and then in the coming 1 or 2 years, it will also appear in the global governing bodies agenda, and member states requested to develop a strategy on this. Climate change, environmental protection are clearly issues that we have to address, particularly for the small countries, small islands, and for the others as well. Globally and regionally, a lot of work is going on, and we have to align these initiatives. And last but not least, you mentioned the importance of pandemic preparedness and response, and particularly the need to strengthen the core capacities under the IHR. And the Director General's leadership in the last years and in the upcoming period is absolutely vital to strengthen pandemic preparedness and response. And then my final comment is about the issue that Malaysia has raised in connection with the upcoming EV in January, where a resolution or decision will be submitted on behavioral change, and we are looking forward to working with Malaysia on that. And then let me join the Cook Island and many of you who said a big thank you to the health workers and the health workforce who worked in the front line during the COVID, post-COVID, including the other frontline workers. WHO considers this a very significant input into the COVID, and I'd like to join countries who appreciated this. Thank you, and obviously we are on the same page, and it's they deserve a big, big thank you from all of us. Thank you very much, and looking forward to implementing and following up on all these issues that you have raised. If Corinne has anything to add before I pass it on to the DG, you are feel free.
Thank you very much, DDG and OIC WIPRO, for giving me the floor. First, honorable ministers and honorable delegates, thank you very much for your comments, for sharing your experience. Thank you very much for your expression of appreciation and trust in the Secretariat of this region, which I'm sure has been touching and is touching a number of our hardworking staff. But it is actually thanks to your hardworking staff and your leadership that we have been able to deliver working together. A couple of things from my side, maybe on COVID-19. The Secretariat would like to commend member states for the regional solidarity and coordination, which has been instrumental to the performance of the region in responding to COVID-19. The implementation of the APSED and investment in preparedness has been key for the region's readiness. But we cannot drop our guard. We must remain vigilant. We must take lessons from COVID-19, and we must continue to prepare for the next pandemic while we still respond to COVID-19. Second point, I would like to mention that a number of you out of the 23 intervention acknowledge the continuous relevance of the For the Future vision, which continue to drive, and that we continue to drive together, building on our learn and improve culture. The practice has been built over the years through APSED, but put under the test with COVID-19 and proved well. And we will continue to fine tune and use it for other areas of work beyond emergencies. You also acknowledge the work done on the workplace culture. It's a long journey, but as I mentioned earlier, the workforce is committed. And a number of you mentioned the sharing of information and experience. We will continue to strengthen the roles that the regional office and country offices have been playing and connecting countries, sharing information and experiences, learning from this, and using this knowledge to better support countries. And the work in country session tomorrow morning will be quite interesting in this regard. I just would like to finish by picking up a point from Philippines on the country cooperation strategy. We are actually looking forward to work with Philippines on the CCS, which will take, of course, into account for the future, but also the new Philippine health sector strategy, which has been developed, as well as the new national objectives for health and the new UN Sustainable Development Cooperation Framework, both of which are underway now and into early 2023. And I will just finish by saying that many mention collaboration, solidarity, partnership, which are values that we really cherish in this region, and we will continue to work in this spirit with all of you. Thank you very much, DDG. Thank you.
Yeah, thank you. Thank you so much. I will not repeat what has been said. I think Susanna has addressed all the issues raised extensively, and Courtney also the rest. Maybe on just few of them. One, on COVID, you have done very, very well. And this is because of your commitment. And you also have experience from previous SARS, H1N1 and MERS. And hopefully the muscle memory helped. But above all, it's the commitment, I think, that is key. And my suggestion here is, to document the experiences in many of your countries, so it can help us for the future. Because, of course, we're saying we're learning the lessons. Some panels have been established, and we had many recommendations. But I don't think the learning process should stop there. We should go deep and understand, especially some of the lessons from you, and document it. That's one area I would like to suggest. But thank you so much for the job really well done in response to COVID. And then the other issue is, again, a recommendation. Malaysia is leading on behavioral insight. Whether it's communicable diseases or non-communicable diseases, at the end of the day, the behavioral issue influences significantly. And that's why Malaysia is preparing to take it to the assembly, and maybe taking it as a regional, as ASEAN and regional agenda. When you push the resolution, will be very, very important. In WHO, as part of our transformation, we have started a small unit, but the support from member states, I think, will strengthen that even more, because the next few years, we have to focus on behavior. The reason I'm saying this is, the first priority should be addressing the root cause of problems, the health problems we're facing. And these are mainly related to behavior. We cannot go on treating the sick while we can promote health and keep people healthy and assure well-being. So that's the second recommendation, for this region to be more vocal on that and help us in making sure that the world focuses on health promotion, disease prevention, addressing the root causes, whether it's social determinants, commercial, or others. And then as a vehicle, we have agreed that, as you know, and many of you have already raised it, the focus should be on primary health care. Of course, that the journey is towards universal health coverage, health for all, but with a strong foundation of primary health care. And on primary health care, there are countries who have good experience in your region. And I would appreciate it if you can also champion this, because for health promotion to succeed, and even for emergency preparedness and response to be realized, investment in primary health care is central, and which you have already said, and your focus on that will be very, very important. I think the rest have been raised, but if there is one thing which we need to also focus is on climate change and health. By the way, my condolence to those who lost their lives, this volcanic eruption. The emergencies are also very common. What happened in Tonga. We have to, support you in having tailored solutions to the type of emergencies you face, tsunamis, volcanoes. But at the same time, investment in climate change and health, especially focused on SIDS countries, will be important. We have a SIDS unit in WHO, and we will work with you in really strengthening in strengthening the health system, making it resilient, and for doing both on adaptation and mitigation. I had a very good discussion with ASEAN countries yesterday, and also with Pacific Island countries. And it was very, very helpful, helped me to understand the priorities, the focus areas they want, and look forward to support based on the guidance and inputs that you have already given. Thank you so much for all the inputs, for all the guidance, and look forward to working with you even more closely. Thank you. But one last thing, I think I said yesterday, but for the second term, your confidence and support means a lot. And thank you so much for your confidence and support. I'm ready to serve and look forward to have some progress together. Thank you so much.
Thank you very much, Dr. Tedros, Dr. Chakap, and Dr. Kapuano. Let's conclude our consideration of agenda item 6 and 7. We now move to agenda item 8 on program budget. You should have before you document WPR/RC 73/3, RC 73/INF/1. WPR/RC 73/4 and WPR/RC 73/4 (1) Program Budget 2020 to 2021 Budget Performance Final Report. Program Budget 2022 to 2023 Update, and the Program Budget 2024 to 2025 respectively. May I now request Dr. Susanna Chakap, DDG and Vipro OSC, to introduce this agenda item.
Representatives. Thank you. I'm grateful to introduce the presentation of agenda item 8 on the program budget. While DPM will be presenting all items in detail, I would like to say a few words on the GPW 13 extension and the development of program budget 24-25. Concurrent global crises are disrupting health systems, weakening populations, and creating ground for new disease outbreaks. In addition, progress on achieving the Sustainable Development Goals is faltering. GPW 13 was approved as the key strategic framework to deliver on the gradual achievement of the Sustainable Development Goals. Yet, COVID-19 significantly delayed the attainment of these targets by 2023, as set forth in the GPW 13. The extension of the duration of GPW 13 to 2025 reconfirmed its goals and strategic directions as reinforced by the 5 priorities outlined by the Director General in January 2022. In this context, the proposed program budget 24-25 will fully align with the directions proposed in the GPW 13 extension, and therefore its overall theme is to consolidate gains, focus investments in countries, strengthen country capacity in order to accelerate progress toward the triple billion targets and health-related sustainable development goals. Putting member states' requests for greater budget, governance, and transparency, WHO in the Western Pacific region has launched an inclusive and participative country-level programmatic prioritization process. One of the key issues raised by member states at recent governing body meetings was the more equitable allocation of resources within WHO. The Secretariat is committed to continuously improve internal allocation of resources, especially to the regions and to country offices. One of the instruments to achieve that was the establishment of the Resource Allocation Committee, which I have the pleasure to chair, where regions represented by DPMs are part of the allocation decisions. This will become increasingly important for WEPRO, where locally raised VC may decrease in the future. Of course, for the Resource Allocation Committee to be more effective, WHO will need more flexible funding, as highly earmarked VCs are already pre-allocated by the donors. As you know, the current program budget 22-23 was revised in May 2022 at the 75th World Health Assembly. The revision had 4 main focus areas. 1, to respond to the recommendations of the various independent reviews following COVID. 2, strengthening the primary healthcare, health system resilience, pandemic preparedness nexus, and strengthening delivery capacity in the country offices. 3, strengthening health information systems in countries. And 4, strengthen accountability in WHO with special focus on PRCEAH. All these priorities will have to be brought forward to the 24-25 budget as well. Strengthening health system resilience is a particularly important topic for WEPRO countries, and it underlines the Director General's commitment to focus on country impact. Moving on to the draft proposed program budget 24-25, first of all, this will be the first program budget which will include a 20% higher SS contribution. This is the result of the work on sustainable financing. In this context, I would like to thank the strong support and the leadership of the WEPRO member states making this historic decision possible. Secondly, program budget 24-25 is the last budget of the extended GPW 13. The task is clear. We have to do our best to reach the triple billion target by the end of 2025. This should be our joint key focus. In September, and early October 2022, WHO representatives and country liaison officers have held technical discussions with their national counterparts, agreeing on where the organization's support should be focusing. These consultations focus on the what and the how, putting member states' needs at the center to further strengthen the collaboration at the country level. The outcome of these consultations have been translated and linked to the GPW 13 results, as well as for the future regional shared vision. You will be presented with the outcome of this prioritization exercise today. With your permission, Mr. Chairperson, I now hand over to the Director of Program Management, which will then be followed by colleagues from WHO headquarters. Over to you.
Thank you very much, DDG and OIC Pro. Mr. Chairperson, distinguished representatives, I'm pleased to present agenda item 8.1 on Program Budget 2020-2021, Budget Performance Final Report, 8.2 on the Program Budget 2022-2023 update, and 8.3 on Program Budget 2024-2025. Item 8.1 on Program Budget 2020-2021 Budget Performance Final Report, document WPR/RC73/3 and its annex provides a final report of budget performance for the biennium 2020-2021 as at 31st December 2021. As you can see in this document, overall funding, utilization, compliance, and controls continue to be strong. Overall, for the Western Pacific region, $347.9 million, or 96.5% of available resources of $360.5 million, were utilized as of 31st December 2021. This level of utilization is higher than the previous biennium 2018-2019 by $78.4 million at the same point in time. To mitigate the impact of COVID-19 on the planned implementation of the Program Budget 2020-2021, the region, at the start of the pandemic, developed a red box or shrunk work plan, which reprioritized activities for implementation while supporting pandemic response in countries and areas. The shrunk plan focused on ensuring the continuation of essential activities and strengthening core health systems during the pandemic. It allowed countries and areas to achieve progress on their priorities, along with the thematic priorities for the future, while supporting governance efforts to ensure that WHO continues to be accountable to member states, partners, and donors. Implementation of the shrunk plan was regularly monitored and adjusted with the guidance of the region's program committee. Prioritization exercise undertaken across regional and country offices demonstrated WHO's agility and commitment to support member states. These actions allowed WHO in the region to direct funds to where they were needed. The Secretariat is working diligently to address all the outstanding recommendations from the recent audits. Accordingly, 34 out of certified internal audit recommendations were closed. Work is also underway to initiate closure on 2 of the 3 external audit recommendations by end of this year. The one that remains outstanding from both internal and external audits is related to updating the country cooperation strategies in the region and aligning them with GPW 13, for which the work is in progress in consultation with member states and partners. Many country cooperation strategies or CCS expired or were approaching expiry during the acute phase of the COVID pandemic. WHO staff, like Ministry of Health and other health partners, were repurposed and focused on responding to COVID-19 delivery of reprioritized work plans, and what member states most needed. It was not the right time to embark in the development of such a strategic document like the CCS. In the region, we apply a learn and improve approach to many areas of work, including the development of CCSs. Building on its predecessor, the fourth generation of CCS will be framed based on the For the Future, emphasizing solutions that are customized to the country's unique context and what WHO needs to do to support the country to travel its last mile to reach the unreached. We now have a staggered plan for CCS renewal. The Secretariat continues to improve controls through strengthened management, training, communications, rollout, and support for corporate policies and monitoring of risks in the region, particularly on prevention and response for sexual exploitation, abuse, and harassment, donor reporting, direct financial cooperation contracts, and the procurement of goods and services. Gender balance and geographical representation of staff continues to be high priority for the region. Significant progress in gender parity has been made through recruitment policy adjustments and awareness raising among staff over the years. The share of female international staff in the region has risen to 57% as of 31st December 2021, from 50% at the end of 2019. We also continue to reach out to unrepresented and underrepresented countries to improve opportunities for successful recruitments. Annex 1 of document WPR/RC73/3 contains the end of biennium performance assessments of program budget 2020-21 and is a summary of progress made against strategic priorities and outcomes within GPW 13. The report covers the period from 1 January 2020 to 31st December 2021 and highlights how the Western Pacific region used its implementation plan for the future towards the healthiest and safest region to advance a shared vision between WHO, member states, and partners to achieve the GPW 13 goals. Before moving to the next sub-items, I would like to propose a small interlude and have a look at some highlights from the last biennium by watching a short video.
The 2020-2021 biennium was one like no other. The COVID-19 pandemic impacted health, lives, and economies, requiring WHO's technical expertise and response at unprecedented scale and speed. It tested our For the Future vision to make the Western Pacific region the healthiest and safest in the world. Throughout the pandemic, the Western Pacific region advanced this shared vision, which is also the region's implementation plan for the 13th General Program of Work. The End of Biennium Program Budget Annex report describes this work. WHO supported member states' efforts to improve essential services while responding to COVID-19. We aim to reduce the number of people suffering financial hardship and improve access to essential medicines, vaccines, and diagnostics. Together with partners, we supported member states to get COVID-19 vaccinations to healthcare workers to protect those who protect us. We also provided countries with the latest guidance and training opportunities, from psychosocial skills to adapting care pathways. The Secretariat worked across its 3 levels to ensure a consistent supply of essential medicines despite interruptions in production and global logistics. WHO in the region helped prepare countries for future health emergencies, including through the response to COVID-19. In Vietnam, we supported the country's swift achievement of 70% vaccination coverage against COVID-19 using a health systems approach. Across the region, we contributed to addressing determinants of health, reducing risks through promoting health beyond health and healthy settings. The Philippines adopted new guidelines to eliminate trans fat from pre-packaged foods. And in line with the climate change, environment and health thematic priority, WHO supported Fiji towards developing climate resilient and environmentally sustainable health facilities. We supported countries to monitor tobacco control efforts and their impact among adolescents through the Global Youth Tobacco Survey. WHO has worked to strengthen country capacity in many areas, including data and innovation, advocacy for health, and effective, transparent use of resources, be they human, financial, or administrative. Throughout the biennium, we have worked to advance the For the Future vision, which has contributed to WHO's triple billion targets and attainment of the broader Sustainable Development Goals. WHO in the Western Pacific will continue to advance the For the Future vision. We are pleased to present the work of this biennium to our member states.
Thank you. Now turning to the program budget 2022-2023 update, I would like to present information document RC73/INF/1. The program budget 2022-23, as mentioned by DDG and OIC WePro earlier, was developed during a unique time. The world faced health, social, and economic consequences on an unprecedented scale due to the COVID-19 pandemic. The original program budget 22-23 was approved by the World Health Assembly in May 2021. In the approval of the program budget 22-23, the Director General was requested by the World Health Assembly to submit a revised program budget 2022-23, including a revised appropriation resolution to the 75th World Health Assembly in May 2022. This resolution was adopted. It is WHA 75.5, providing an overall increase of $604.4 million to the program budget 2022-23, of which 51.3 million is for the Western Pacific, bringing the region's budget to $403.2 million in accelerating implementation of For the Future as the plan for the GPW 13. The increase for strategic priorities 1 and 3 was planned to strengthen support in the 30 countries with the greatest SDG gap globally. The region will identify 3 country offices for this initiative to strengthen WHO support to member states towards UHC. Criteria shared by headquarters to assist in the selection included, among others, Universal Health Coverage Index, health workforce, essential health services disruptions due to COVID-19, gross domestic product growth, international health regulation self-assessment. Turning now to the program budget 2024-2025 and document WPR/RC73/4, WPR/RC73/4 Core 1, and RC73/INF/4. Document WPR/RC73/INF/4 presents the outcome of the program budget 2024-2025 country prioritization process. Globally, regional strategic priorities were to be discussed during the annual sessions of the regional committees prior to the country prioritization process. However, in the Western Pacific region, the process had to be adapted because of timeline constraints, as the hard deadline to submit regional input to headquarters is set just 1 week after the end of this regional committee. Hence, the country prioritization consultation have been held before the regional committee. Starting late August until early October 2022, WHO representatives and country liaison officers have held technical consultations with their national counterparts, agreeing on where the organization's support should be focusing. While the bottom-up approach is not new to the region in the context of strategic planning, the globally harmonized and strengthened process provide a great opportunity to develop a stronger narrative for the program budget 2024-2025. The outcome of the strategic consultation shows a high degree of continuity with the current program budget 22-23, which clearly evidence the relevance of For the Future thematic priorities and operational shifts in implementing the GPW 13 in the region. Furthermore, the result of the country prioritization process demonstrates clear alignment with the 5 priorities guiding the extension of the GPW 13 to 2025. The exercise reinforced WHO's regional strategy and vision to public health challenges and will serve to inform the global proposed program budget 24-25 being drafted by headquarters. This element will also drive the operational planning and implementation of the program budget 2024-2025 once approved by World Health Assembly 76. Now, with your permission, Mr. Chair, I would like to give the floor to Dr. Jana Risager, Chief Budget at WHO headquarters. Dr. Risager will present on the overall program budget 2024-25 development process, the global context, and the way forward. Jana, I know it's very early for you. Thank you for joining us, and you have the floor.
Thank you very much, Mr. Chairperson, distinguished representatives. Thank you very much for giving me this opportunity to address you this very early morning here in Europe on the subject of the global process for the draft proposed program budget 24-25. In the past 1.5 years, program budget, its development, its implementation, and its financing has had a prominent place in the conversations with the member states and among the member states. During the Sustainable Financing Working Group and in the recommendations which were adopted by the 75th World Health Assembly, there were several very important proposals for the program budget and asks from the member states. Next slide, please. You have stressed that priority setting should be a cornerstone, should continue to be a cornerstone of the program budget development. But you ask for it to be a stronger process, a more harmonized process, a more transparent process, and a more inclusive process in which all member states can participate, can share the ideas and priorities, and can transparently see the priority data across the 7 major offices of the organization. Member states also ask to be much better involved and more often have the checkpoints in the program budget development so that they can provide the guidance, so that they can be better informed also for the moments where decisions are made on the program budget. Also, many member states said that the current format of the program budget is somewhat complex. It's difficult to follow sometimes, and we were asked to consider a better format for the program budget presentation, somewhat simpler, clearer, but the program budget that still has relevant details and level of details for decision making. As the Deputy Director General just mentioned, the program budget 24-25 will be the first program budget with a 20% increase in assessed contributions. And with the increased assessed contributions, member states also expect to have greater transparency on the resource allocation and resource deployment. As the program budget 24-25 development has to start right after the 75th World Health Assembly and after the recommendations of the Sustainable Financing Working Group were adopted, we seized the opportunity to implement many of these asks and proposals already in the program budget 24-25. So next slide, please. So we started with the country priority setting, which was the focus of the development of the program budget development so far. And you have just heard from the Western Pacific region presentation on the budget that the process started in August and will continue until the regional committees. What's new this time around that we are going through a harmonized approach across all the regional offices. There are, of course, variations and specificities, but there is a minimum criteria for the priority setting. We've all agreed that global and regional priorities will set the scene for the country priority setting. and they will inform the process and provide strategic direction. Regional committees are an incredibly critical step in the priority setting in the program budget development process. And there have been many consultations ongoing in the regional committees, just like today in the Western Pacific region, and many more to follow. And now country priorities will inform and guide the program budget development at the regional and especially at the global level. Next slide, please. The document in front of you summarizes the regional and global priorities or areas of focus. So I will not repeat them here. I'm sure you're very well familiar with them. And if you could please give it the next slide. But what we would like to also strengthen as we go forward for the program budget 24-25 is the link between the priority setting process and other relevant steps, both in the development of a program budget and in the implementation of the budget. One, there has to be a very clear link between the priority setting or the priorities of the identified and the budget allocation to the program results, which should also inform the program budget costing. And two, it's a positive departure from the way we approach it today, and 20% increase in assessed contribution will also help this process. Is the link between the priorities and financing. What we would like to see in the program budget 24-25 is a much better level of financing of the priority output. We'll have to see when we have all the priority data coming in from the 6 regional offices and their country offices to be able to identify commitment level. For example, here we give 80%, but we will of course inform you once we have all the data together what that percentage would be, to which we will fund all priority outputs, or at least we will make a commitment to fund them. Of course, that will necessitate an alignment and a work together between the 3 levels of the organization, because the resource allocation, of course, is not is a work across the 3 levels. Next slide, please. The program budget level for 24-25 is proposed to retain the same figure, the same level as in the revised program budget 22-23 at approximately $4.9 billion. We believe that what we really have to strive for, and this is also what Deputy Director General highlighted, is that the program budget 24-25 should be about the consolidating gains of the GPW 13. So we believe that the level of the revised approved budget is the right level for that work. However, what we would like to see changed is the share of the budget for the country offices. The graph in front of you shows that in the course of the GPW 13, the share of the country offices budget has steadily grown from 39% at the start of GPW 13 to the proposed level of about 48% in 24-25. This is approximately 19% increase in the country offices share of the budget in the course of the GPW 13. Next slide. And again, next slide. Next slide, please. Yes, and as was also mentioned, the program budget share for the Western Pacific region has been growing as well during the GPW 13 biennium, and it is proposed to be at the level of $408 million in 24-25. Next slide, please. So the format of program budget presentation, as I mentioned earlier, many member states commented that current budget is somewhat complex and it really needs to be maybe redesigned or revisited to make it simpler and also to make it more modern. So we have been looking into a modality in which every module of the program budget could stand on its own right and could be read independently from other modules. We would like to introduce several new parts to the program budget. For example, the executive summary should be a summary of the entire budget, of main issues, of main budget figures, which could stand on its own and could be a short summary of the entire budget that could be easily read and understood, hopefully. What we would also like introduce as is what we call a PB verse. Is the program budget, which will have both the paper copy to it, much leaner, much sharper, but also a digital platform to the program budget, which will contain the information in a much better presented form, with the infographics, with the better tables, with the better overviews on the outcome narratives, on the output narratives. We also would like to add, and we're currently working on it, 2 dashboards which will accompany the program budget. One which will contain the country prioritization data across all six regional offices, where we would be able to see specifically how priorities set in every region, how they compare, how they aggregate to the global level, to respond to member states' ask on a more transparency in the prioritization for the program budget. Another dashboard that we would like to propose is on the budget overview. Again, it's a little bit more user-friendly way to present budget figures with more details, which would also allow to zoom in and zoom out in different budget slices. Another thing that will be added to the program budget is what we call program budget explainers. And again, we've heard a lot during Sustainable Financing Working Group that the maybe budget processes of WHO are not always easy to understand, and therefore it would be helpful to provide some information, some background information on the budget structure, on the budgeting process, on the costing process, on the prioritization as well. And another item that comes over and over again, but it still would require a lot of conversations with the member states, is on the costing of the resolutions and how this comes into play during the program budget development process. Next slide, please. And so in my final slide is just to summarize the consultative process of the program budget development up till the assembly. So we are with the Western Pacific Regional Committee, we are finalizing the regional committee's consultations on the program budget. There will be some additional meetings in several regions, which started their priority setting exercise after the regional committee. So they will meet in some form to go through the priorities before they become part of the global process. We are having a special session of the Program Budget Administration Committee on the 17th of November, where we will discuss the prioritization for the program budget with the earlier results that we are having already. There will be further deep dives and the consultations before the executive board, where we will present the status to date in the program budget development, and maybe looking in some specific areas in a greater detail to be able to answer questions of the member states, so that member states feel they're well prepared for the final decision at the World Health Assembly. Thank you very much.
Thank you Thank you very much, Jenna. And I now hand over the floor back to you, Mr. Chair. Thank you.
Thank you very much. Time is up, but we will now suspend discussion to break for lunch on the 27th floor. There will be a side event on toward more ambitious public financing to sustain the healthiest and safest region at the 12:45 hours Manila time here at the plenary hall. The same Zoom connection links will be used. See you back here at 12:45. Thank you very much.
Thank you.
DDG, for those opening remarks, and you've outlined, I think, some of the critical reasons why it's so important to have this side event today and the importance of public financing for health. I now turn over to our moderator for today's discussion, Mr. Luis Vinales Torres. He's the coordinator for health policy and service design. Over to you, Luis.
Thank you very much, Martin. Welcome, delegates, welcome, participants. Let me put in a couple of graphs some of the key points that Dr. Jacob has just shared. Please, first slide. This meeting is trying to look at how financing contributes to UHC, and as our Deputy Director General mentioned, we have done excellent job on increasing coverages, increasing services in the two dimensions of universal health coverages. If you look at the yellow line, we are the region, the WHO region, that has made a more spectacular job pre-COVID in terms of increase in the service delivery index. As Dr. Jacob also mentioned, though, we are not in the right direction when it comes to financial protection. We have also gone the wrong way in terms of both catastrophic health expenditure and impoverishment due to health. Next slide. Many of the good news that we have seen in the last decade is countries have done a very good job on, for example, increasing pooling of funds. Schemes have been created, cost sharing has been improved across different population groups in countries. However, on the other two health financing functions, resource mobilization and purchasing, there is clearly room for improvement. We can observe on the graph on the slide that prioritization of public resources to health has been stagnant. Also, next, we can see that many of the resources might not go in the sectors or in the structures where we can make a big difference on improving financial protection. For example, catastrophic health expenditure in the region is being driven mostly by outpatient medicines, but most of our spending is increasingly going in hospitals. Next slide. For today's session, we have 4 objectives. Which is we want to recognize the health financing progress achieved in the region. Also, next 2 points, please. Explore sustainable health financing strategies and listening to countries how they have been doing in the recent past. Reiterate the importance of effective public spending for universal health coverage and stimulate further engagement with the Ministry of Finance to invest in health. For this important meeting, we have distinguished panelists, 4 that are going to bring different perspective on the challenges that member states have been facing on health financing for UHC in the recent past. The first speaker, joining us from Washington, we have Krzysztof Kulowski, which is the World Bank Global Lead for Health Financing, which will briefly share what are the current and short and mid-term economic outlook, and also to see how we can better collaborate Ministry of Finance and Ministry of Health in this current situation. Krzysztof, thanks for joining us so late evening in DC. The floor is yours.
Thank you much, Luis, and for the opportunity to share some insights on 2 critical aspects of health financing with you today. First, the impact of the current multiple economic shocks on health spending, and second, opportunities to strengthen the collaboration between ministries of health and finance as a prerequisite to increase public investment in health. On the first point, 3 forces are currently at play that slow down economic activity and growth. First, public health measures to control COVID-19. Second, inflationary pressures. And third, debt distress. Against this background, let's have a look at the growth prospects in the Western Pacific region. As you can see in the slide, the recovery from the great lockdown looks very different across country groups. High-income countries and upper middle-income countries are expected to see a strong rebound. However, in upper middle-income countries, growth prospects fall short of pre-COVID-19 trends. Lower middle-income countries will see a slower recovery and only a return to pre-COVID-19 levels of GDP in 2023. Small island states, however, are expected to have on average a slow rebound and low growth prospects in the medium term. As a result, they will be reaching pre-COVID-19 GDP levels only in 2026. From a health perspective, what is even of greater interest is the ability of countries to build out public investment. As you can see in this slide, like in the rest of the world, we see large and growing disparities in the Western Pacific region. For example, 6 middle-income countries are expected to see a substantial expansion of their general per capita government spending. That's the good news. However, in 4 middle-income countries, growth in government spending will be lackluster. And finally, in 6 middle-income countries, general government per capita spending is expected to decline and remain below pre-COVID-19 levels in 2027, that is 5 years from now. So what does that mean for health financing? Please, the next slide. First, countries in the region face very different prospects for growth in government per capita spending on health, the blue line in these graphs. In some countries, it will contract, in others stagnate, and in some expand. Second, unless governments take bold actions, growth in government per capita spending on health will fall in all country groups short of pre-COVID-19 trends, the orange lines. So how to close this gap? As you see in the next slide, substantial increases in the priority given to health and government spending decisions will be necessary. In the 6 contraction countries, it will require on average an increase in the health share of government spending of 5.5 percentage points between 2019 and 2027. And as you can see, even in stagnation and expansion countries, the necessary increases are substantial. So what will it take to increase the share of government spending on health? Let's turn to the next slide. In general, the case for investing in health is strong. The argument has been developed over the past 50 years from a recognition that government intervention is necessary, as many health services are public goods, to the substantial economic returns of investments in health. And the COVID-19 crisis has certainly strengthened the case. However, the argument for investing in other sectors is equally compelling. Think of education, social assistance. And the reality is that we heard already from the DG, in many countries, the priority given to health and government spending remains low and has been stagnant. So during the the Japanese presidency of the G20, we had the privilege to explore with ministers of finance and health what can be done. The next slide, please. The emerging consensus has been well documented and speaks to the need for collaborative leadership of ministries of finance and health in 4 areas: health budgets, health sector policies, the macro criticality of health sector spending, and government-wide fiscal policies. Let me share with you some critical priorities and examples of progress in each of these areas. The next slide, please. First, ministries of finance and health must work together to define, demonstrate, and ensure the impact of additional spending on health. In many places, however, public financial management in the sector remains subpar and not fit for purpose. In response, more than 20 countries are today, as a priority, extending the reach of public financial management systems to include service providers. 3 good practices are emerging. These ensure not only that resources reach the providers, in particular primary healthcare providers, but that there is also full accountability for the use of funds and the attainment of results. Second, ministries of finance and health need to work together on health sector policies that are of vital interest to both. Following the example of the Philippines, governments are now earmarking revenue from indirect taxes, like health taxes, but also value-added tax and various levies to expand social health insurance to the poor and other vulnerable populations. For example, in Egypt, the Ministry of Finance, Ministry of Health, and the newly created Social Health Insurance Agency work together in putting such earmarks into place to achieve universal health coverage over the next 10 years. At the G20 meetings, ministries of finance and health also agreed on the need to better understand when and how health spending can affect macroeconomic stability. In practice, this means that countries develop the ability to systematically assess health expenditures and revenue in the medium term, that is over the next 3 to 10 years, identify the threats and opportunities, and develop strategies to deal and seize them. This agenda will gather further momentum when the IMF will start assessing the macro criticality of social spending as part of Article 4 monitoring next year. Currently, we in the bank are working with Jamaica and Mexico, for example, in assessing what the health financing future holds in both countries and in developing strategies to tackle challenges to its resilience and sustainability. Finally, it is important for ministries of health and finance to work together in ensuring that sector policies and reforms align with growth and poverty reduction strategies. Often we see a glaring disconnect. Moreover, ministries of health can play a critical role in supporting ministries of finance in expanding fiscal space and strengthening fiscal sustainability. For example, ministries of health increasingly work with ministries of finance in laying the groundwork for a reduction of fuel subsidies, often a large expenditure item to cut back on ineffective expenditures and thus increase the fiscal space. Let me conclude by saying that, of course, the involvement of other actors is critical, yet as the G20 summit stressed, the collaboration between ministries of finance and health must be centerpiece. With that, thank you, and back to you, Luis.
Thank you very much, Christoph, for your excellent presentation. It's great to hear not only their situation that we are facing, but plenty of options and hope, and also concrete examples of things to improve the dialogue, MOF and MOH, and policies to keep this fiscal space for health. Now, I would like to turn into the rest of the panelists of this session. We have with us the Honorable Minister of Kiribati, Dr. Tinte Iting Teong. We have with us also the Director General of the Ministry of Health in Mongolia, Mrs. Mungtul Badbatat. And to my left, we have Dr. Sungsup Ra, which is the Chief Sector Officer in the Sustainable Development and Climate Change Department from the Asian Development Bank. Without further ado, we would like to hear from very different contexts. As you can see, we have two countries with very different realities. One islands country in the Pacific, and Mongolia in the heart of Asia, which have faced, I would say, different challenges but common problems. And we would like to see how they have been dealing with the COVID response, and how the learnings that we have seen on the area of health financing during COVID response can be used for dealing with the futures in the short and mid-term. So before, I would like to turn to the Honorable Minister of Kiribati and ask, I'm curious to learn, what were the prominent challenges that you faced when the pandemic began, and especially on the financing front? What are the lessons that the country drew from it, and what could be applied for future pandemics, but also for the other health financing related challenges that you are facing? Honorable Minister, the floor is yours.
Thank you, Chair. And before I start, on behalf of the government and the people of Kiribati, I would like to greet you all in our local language. It is truly an honor to be here this lunchtime to share with you some of the challenges, some of what we faced as a nation, as an island nation, straddling the equator, which will hopefully give some insight to this region, to the Western Pacific region, of some of the exciting challenges that we have faced as a country. Our unique geographical isolation and the dispersion of 32 islands, inhabited islands, across the equator and the international dateline gives Kiribati a unique perspective on the recent challenges that we experienced during the COVID-19 pandemic that reached our shores in February of this year. Before I comment any more, Chair, we'd like to acknowledge the continued support from our development partners, the governments of Australia, New Zealand, China, Japan, and the USA, to name but a few, during the most recent COVID pandemic. We are also grateful for the multiple agencies that have provided strong support and strong guidance to our country, namely WHO, UNICEF, SPC, among others. It is a frightening reality, Chair, and I speak this as a Minister of Health in a country that experienced COVID for the very first time in February of this year. We had never had a single strain of COVID prior to that. We were not a privy to the Delta strain, so we were very protected. But it was that very same protection that gave us a lot of challenges when COVID actually reached our shores. I was there, Chair, and so was my president and the whole of government. And when the COVID-19, the Omicron variant, reached our shores, within a week or 2 weeks, our health infrastructure, our health was virtually on the brink of collapse. Our staff were all sick. Patients were queuing up at the clinics and at the hospitals. It was very sad, but it was real. And we, as a government, had to own the problem. We knew from the start that we could not manage this on our own. So we turned to our partners, we turned to them for help, and we are grateful. The support that we received from the governments of Australia, the governments of New Zealand, WHO. By this, I mean the things such as the OSMAT team that were able to come into the country, provide the support, the WHO consultants, technical advisors that were able to come and land and work with our staff, gave the staff the morale. It actually gave them that psychological boost that they needed. If they had arrived 1 or 2 weeks later, Chair, I can certainly say that we would have been in total collapse. Not an ideal situation for any government to be in. But so we are grateful. The government of Kiribati extends its gratitude to all of those partners, some of which I may have neglected to mention, but these are some of the examples. These are some of the challenges that we face as an isolated country of scattered islands in the middle of the Pacific. And with those words, I'd like to thank you, Chair.
Thank you very much, Honorable Minister. It's important. I appreciate your words of thanks to the international community for timely support and achieving good results during the acute phase of the pandemic. Now, let me turn the floor to Director Bat Batar from the Ministry of Health of Mongolia. We acknowledge that Mongolia has achieved substantial progress on very demanding health financing reforms You have set a purchasing agency. You have increasing your entitlements. You have moved to sophisticated provider payment mechanisms. But the current fiscal situation, it's challenging and putting a stress to these very well-designed reforms. Can you share a bit what has been the response to COVID, but also particularly how you are facing these challenges? Over to you, Director.
Thank you. I would like to extend our gratitude to the WHO country and regional office for its continued support for strengthening healthcare system in Mongolia. So one of the major reform in the health system in Mongolia is health financing system reform since the year 2021, introducing strategic single purchasing system to achieve universal health coverage, to fund quality healthcare services and shifting towards better health services at all levels, leveraged by fiscal policy. Legal acts and regulations, including contracting, costing, tariffs, and monitoring, is continuing to be revised and in formulation based on the needs and requirements to ensure smooth transition at all levels of healthcare institutions and hospitals to mitigate both operational and financial instabilities and external shocks, especially during pandemic shocks. The reform process coincides the COVID-19 pandemic outbreak, which adversely affected some reform activities. In particular, the health financing reform impact couldn't be evaluated with the disruption of COVID expenses and impact on the health expenditure as a whole. 1/3 of the health insurance fund dispersed to medical care and services against the pandemic in the last 1 year. The reform impact can only be starting from second half of this year, 2022. We are in a learning stage. We are carefully investigating the gaps, bottlenecks, and conducting systems thinking approaches to find acupuncture points to avoid any disruptions on the delivery of healthcare systems, even in the remote. However, there are pressing issues on healthcare system that needs to be improved and strengthened, including better health insurance fund management to ensure sustainable financing and efficient allocations of resources where we might face hospital-centric financing, passive purchasing, and increasing out-of-pocket expenses. Second, prioritization of investment needs in the sector and in the most remote areas as well. Cost containment techniques and strategies to make the available funding as well. And then the last, the management of human resources. The shift from paper-based medical records just in the last year on the both public and private institutions into integrated health information database aims to further enhance the health sector information system and finding gaps in all sorts. We are also mandating to use internationally accepted clinical guidelines, up-to-date solutions at all levels, even also in the remote areas. However, there is still struggle on both advancing technical equipments and capacity building of staffs to connect to health insurance agency system for claims, acceptance, and accreditations. However, this is a major leveraging stage to advance the health information system and database for both decision-making and strengthening healthcare based on evidences. So we make sure that it will continue and then strengthened further. Strategic purchasing and treating public hospitals with more flexibilities on its financial management and operations require managers of the hospitals and hospital governance to further rethink and redesign to more accountable and bringing more intelligence to the sector for sustainable financing as well as maintaining good governance. So we are shifting to more performance-based financing, performance-based outlooks, and then accountable purchasing, the better hospital governance, SDGs and policy-aligned budgeting.
So with the further efforts, we foresee and then expect the quality healthcare based on the evidences and then equity healthcare in Mongolia.
Thank you very much, Director Mungtul. It's very interesting, the willingness of the country and the system to recognize that this is a learning process and that your incipient reforms will need a lot of additional work, especially in this dear situation. I like your particular references to cost containment and also to the role of information systems that might have to improve your capacity to introduce the performance-based payments and to increase efficiency. And I'm bringing these points here because I want now to hear from Dr. Sung Sup Ra from ADB. ADB is a privileged partner in the sense that knows well the Ministry of Finance, knows well the Ministry of Health, and the words that Director Mungtul was sharing, I think that's something that definitely would sound or would be received well by Ministry of Finance in this effort that we have to do to feed this or to improve this dialogue, Ministry of Finance and Ministry of Health. More concrete, Dr. Sung Sup, where does ADB see this MOH Ministry of Finance dialogue delivering real health financing reforms, and what for you would be the drivers of success for these dialogues to work? Over to you. Thank you.
Thanks, Luis, for introducing me and also asking very difficult question. Before starting, I'd like to thank WIPRO inviting me to this very important panel. Also, while you didn't ask, but I'm thinking that what Kiribati doing and Mongolia doing are great, particularly Kiribati. The example really telling us that how disruptive COVID-19 was to the your health system. And I really commend your government effort to sustain the health sector budget during the emergency situation. For Mongolia, I just take 2 points. The increase in coverage of health insurance to the vulnerable population. Second, that progress in merging government, the budget, and also social health insurance into one single pool. That I think the quite remarkable. The second question, your first question, the most important question is about the MWEB finance and health dialogue. This is really important because health sector people sometimes talk about financing just within your group. It's very important to you go and talk to finance people and then hear what they are saying. And same also finance people, rather than keep talking about problems of the health sector, about their inefficiency, often they talk about that. It's better also they step up and then communicate with the health sector people, given the importance of the paramount importance of the health sector now. So we consider dialogue between the Ministry of the Finance and Health really critical to financing the Sustainable Development Goal. And 2020, WHO and ADB, we worked together, host a virtual meeting of a group of the ministers from both domain, finance and health, at the ADB annual meeting. We also try to do it, repeat this one again, 2023, next year, ADB annual meeting in Korea. Hope that we can get some good results, and then hope that also here, health minister here also can attend that meeting. During the pandemic, countries in the Asia Pacific, all the region, all countries have done, I would say, superb job to respond to the crisis, and also roll out the very challenging vaccine, COVID-19 vaccine program. I think this is time we can really congratulate the excellent work done all over your country, because 2000 when the COVID-19 broke out, I was in charge of the COVID-19 response team in the ADB. Then I know how much work have done all of you to respond to the COVID-19, that issue. You know, the challenge we are facing was really serious, but somehow we were able to respond to them. Come back to this very good example, one good example. Of course, like all of your country did so well, but since I am in the Philippines here, give the example of Philippines. Philippines did also excellent job in this area. The 2020 budget deficit in Philippines jumped significantly to about 8% of the GDP. That's really big number. Despite this, the budget deficit, this Philippine government was very supportive to the Department of Health's decisive response to the pandemic under government program Bayanihan to Heal as One Law. And then the ministry, the government was able to that time mobilize USD about $8 billion for the law. That was a very significant share for the health. That really helped the Philippines effectively, safely respond to the COVID-19 pandemic. From 2019, Philippines also has embarked on a major health financing reform under its UHC law. We, ADB, really commend the government on making the change to how funds for health are mobilized and allocated to realize the vision of this law. And then the ADB, in fact, is supporting this UHC health reform. We already processed $600 million loan last year. We are also now working on another second batch of loan. The amount hasn't decided, it might be around 500 billion. This Philippine experience suggested very important two issues. First, as the DDG Vairago mentioned, important point, that the a whole of government effort. Philippine government, like many of your country, like you mentioned about whole of government, in also Kiribati, took a whole of government approach to respond to the crisis and also to there. So this is such important. The second one, I would say, is that not just only supply driven, the Philippine government, in fact, started it demand-driven approach. What is the meaning demand-driven approach? Like the Mongolia did it, the Philippine government expanded its coverage of the health, and then to every Filipino. Now, this is a completely different ball game. Thirdly, now the demand-driven is important, but that will cost more. The supply-driven also, supply side also government did a lot. Government also create the accountability mechanism led by the Ministry of Health. All of them, they have to deliver efficient services and management. So these all three make the Philippine experience very different. I know not only Philippines, many of your country doing that, but I like to share that. These successes are quite relevant to many of our member countries. Particularly, some country has the physical stress. For example, like Sri Lanka or perhaps Laos. Now many countries are facing quite serious physical stress. And in the case of the Sri Lanka, also has initiated very important reform. That is they try to now improve the quality and utilization of the private healthcare services through transforming its healthcare delivery model into network with the shared care across meaning by strengthening referral system. But this effort will make the system more resilient and also cost more effective, and then even better provide better services at the low cost. We also support Sri Lanka together with the WHO to country can identify option to increase the physical space for health and improve the physical sustainability. I look forward to engaging with all of you in continuing the excellent work in health financing. Thank you very much.
Thank you very much, Dr. Sung Sup. Definitely, if I echo your words, I think we should really take this opportunity of dialogue that the current situation is forcing us to take, no? And you mentioned efficiency, and probably it's try to, I would, if you allow me, I would kind of translate it into how we can build a joint narrative, Ministry of Finance and Ministry of Health, where while we provide these efficiency gains, we also set the basis for these continuous reforms that the Ministry of the health sector needs to probably uptake that will help and enable the progress towards UHC. I think my take from your words is let's use this opportunity that we are facing now. Now I would like still have few minutes, and I would like to perhaps give the opportunity to our Honorable Minister or Director Munitul, if you want to have a very, very quick reflection on future. No, we are talking about what we learned, what is the current situation. Christophe has brought us, on the one hand, the challenging of the forecast, but on the other, some options and some hopes of things to be using health financing to improve the path towards UHC. Honorable Minister, if you want, you may please.
Thank you, Chair. It's I guess it's a bitter reality, and the data that the World Bank showed on the presentation gives us even more grim news. But despite that, I'd like to think that with our country of Kiribati, we approach life in a very optimistic fashion. It is the true Pacific way. And just to give you some statistics or some data, pre-COVID, i.e. 2020, our GDP was just over $120 million. Last year, our total government budget for this year is just over $300 million. And of that, about 35 million was allocated for the Ministry of Health. So just over 11% of our total government budget is allocated to the Ministry of Health. If you put all that aside, Chair, and then you face the grim reality that we face within the ministry, the government of Kiribati is unfortunately one of the few countries in the Pacific with one of the most high burdens of disease. And we don't really need to look very far, because a lot of those statistics are here. They come out of the WHO. In the region, we have one of the worst under 5 mortality rates. In the region, we have some of the worst incidents of TB and leprosy. And these are just a few. The list obviously goes on. And the reality is, for a small country such as Kiribati, with a relatively small amount of GDP, we occupy some of the worst health statistics. And some of them are actually getting worse. And these are the challenges that we face as a nation, that we face as a small island state. How do you finance, or how do you push the value of the health dollar in an already constrained, in an already limited financing sector? But before I carry on, Chair, first of all, I'd actually like to to show our gratitude to the ADB. They actually provided us US $8 million to support us during our COVID-19 crisis, and we're most grateful for that. But I think, as mentioned before, a lot of these challenges create wonderful opportunities. And I think we have to be innovative, we have to be creative. And we thank our partners that have contributed. They actually contribute a lot to our public health programs. The New Zealand government for our NCD program, the Australian government for a lot of our public health measures. And I think it therefore is upon us as leaders within the health sector and as leaders within our own respective governments to be innovative. And to speak on that point, Chair, I think one of the things that we've done as a government since relatively coming out of the pandemic is we've started to reach out in spaces that we have not done before. We've started to, an example that I mentioned is the collaboration that our government, we recently signed an MOU with Médecins Sans Frontières. Last week, I was a party to that. And we've agreed that Médecins Sans Frontières will help address under 5 mortality rates. They will also extend primary health care to some of our southernmost islands that are the hardest to reach from the capital, as well as helping us support some of our infrastructure in these relatively remote parts of our country. Another example that I'd like to speak of is the Pearl project, which is supported by WHO and the Department of Health from the Australian government through the University of Sydney. This wonderful project, which has only just kicked off 2 or 3 months ago, aimed at eliminating tuberculosis and leprosy in Kiribati. I think are wonderful, innovative ways in which our limited health dollar can go even further. This is obviously not understating or undercutting our current development partners, and we're grateful for that. I've already mentioned New Zealand, Australia, and obviously China. And I think within the resources, the limited resources that we have as a country, these are wonderful opportunities for us to collaborate on and for us to share with our fellow member states. Thank you, Chair.
Thank you very much, Honorable Minister. I like you brought the long-term sustainability and you linking it with value for money. You are trying to stretch the health dollar you mentioned, and also the link to primary health care, as I show in the first slide. We probably need to better finance primary health care if we want to first be able to accommodate to the workload related to NCDs that you also have alluded, but also to tackle financial protection. Let me turn finally again to Director Mungtul, I think on sustainability and affordability of the system, if you may. Over to you.
Thank you, Luis. So Mongolia is now the most vulnerable to external shocks on its health sector amidst of global economic situations and post-pandemic recovery, when the country's majority of medicines and medical supplies are import dependent. So global budgeting from Ministry of Finance puts more pressure to Ministry of Health, the sector itself, on cost containment, leaving little room for adjustments of inflation rates, increasing price of medicines and logistics increase, and medical supplies, as well as localizing evolving technological changes during the pandemic. Improving primary care services and limiting hospital-centric financing, which always had been the trend in Mongolia, is a pressing issue and then pressing struggle for us. The share of the health sector budget is approaching to reach to 12% of the government budget, 4.2% of the GDP. It's a tremendous improvement compared to 2 to 2% where it was only 2 to 4 years ago. Out-of-pocket expenses reduces from 36% where it was in 2018. Now we are expecting it's reduced to 25% in 2021, and then we are expecting further increase with the adjustment on the co-payments and then further adjustments. There is an increasing trend of hospital tourism flowing to developed countries, which further pressing the sector to secure the system as well. There is a strong expectation than ever from the Ministry of Finance and strong commitment from the Minister as well at the same time. So we are further rethinking strategic allocation of resources, using the most optimal financing tools and leverages for strong monitoring of the performance of the health sector. Of course, the prioritization of the investment and allocations, and then the human resource posts, pooling of more quasi-fiscal funds, strong coordination and synergies between donor funds and assistance, revenue diversification, is another issue that securing the revenue sources of health sector financing is still under negotiation, including premiums, which has not been changed over the last decade. Public-private partnership is also part of the discussion, which is utilizing domestic resources to its extent possible. So in a way, just to summarize, we are shifting from input-based to performance-based planning system. We are trying to use big data as much as possible to retrieve the real picture of the whole system, to see the real data lively from the remotest as much as possible, to find the most suitable, timely solutions to sustain the financing, as well as to deliver the healthcare in a timely and then to continue to provide the essential healthcare system in Mongolia. Thank you.
Thank you very much. Again, Dr. Muktul, it's amazing the range of reforms that Mongolia is pursuing together. It's difficult to see the amount of different and ambitious reforms that you are trying to push. And I think that if I could talk on behalf of ADB and the World Bank, I'm sure that all the partners in this room are really willing to support Mongolia in this journey. Finally, talking about the World Bank, we like to give if you, Christophe, again from DC, you have few insights that you would like to share with us, more looking forward on what you would like or you will see as about the work of the World Bank or the overall situation of health financing in the region for the future. Over to you, Christophe.
Yeah, thanks, Luis, for the opportunity for a couple of closing remarks. First of all, congratulations to the countries. I think it's fantastic to hear that they're seeing this crisis as an opportunity. As you said, the Mongolia reforms are impressive, but also from Kiribati, how the government is managing the difficult situation right now in a very creative and innovative way. What I wanted to flag is that spending needs are up. So we go into an economic crisis where the spending needs in the sector are up. And that really creates this kind of massive stress that we see across the globe in countries. And with that, as many of you, some of the speakers highlighted, the focus is on efficiency. If the pressures go up, it's not only in efficiency improvements, but then it's also on saving options in the sector. And that's where the sector is extremely vulnerable. So I think I just want to flag that. It's also about protecting expenditures, line items that we know from the past have a detrimental effect on population health. This is particularly maternal and child health and nutrition services, but also mental health services in the current context that need to be protected. The second shift, what we see right now in countries happening, is that there's a discussion to redraw the boundaries between public and private spending. That is, there are concerns, and we know this from past crises, that more of the costs will be shifted to the patient, to the people in terms of out-of-pocket expenditures. And I think that's where you're running a big risk right now, because due to COVID, we haven't done any of the household services surveys. So we don't really know what happened during the first 2 years of the crisis to out-of-pocket expenditures. We see the first results coming in. They are up in some countries, in others they are not, but where they're not up, we see more foregone care. So we see a setback on the path towards universal health coverage. I wanted to flag this. And second, I think in terms of what we intend to do, I mean, it's the whole spectrum of support to reforms, but where we put much more emphasis, and I'm happy to hear this from Mongolia, is that we have to develop more health financing capacity, particularly when countries move from supply side to demand side financing to performance-based financing. There's a lot of demand for capacity development in purchasing agencies across the globe. So that's where we will put an emphasis on moving forward to help countries reap these efficiency gains that are necessary in the sector, but at the same time to build the capacity to engage with the ministries of finance and find, as I said, collaborative solutions between finance and health, that we don't see a major setback as we move forward on the path towards UHC. So thanks again, Louis, for the opportunity. Back to you.
Thank you very much, Christoph. And again, apologize to keep you awake so late. Just two references. I think that your point on foregone care and monitoring, that I think it's a collective effort that we need to work on. And I like that we are ending this interesting panel with this positive mood, as seeing it as an opportunity and the willingness to work together with finance and with partners. Martin, over to you.
Thank you very much, Luis. And first of all, a huge thanks to all our panelists who have contributed to the discussion today in the room, and to you, Christoph, from Washington in the middle of your night. This is a really important discussion as we think about financing of health and healthcare up to 2030 and beyond for the SDGs, universal health coverage. We know we have some difficult years in front of us, but we need to have that longer term time frame and vision. And I think that today's panel has shown us the importance of why that is. It was very clear from the minister's statement, but also has given us hope that there are many actions that can be taken, steps that can be taken within ministries of health, but also between health and finance, to be able to find a way towards having sustainable domestic financing for healthcare. We see this as the start of a discussion. We will continue to discuss this with many of you partners in the coming months and years as we work together to make sure that we can achieve that sustainable domestic financing for health. Thank you all very much. The side session is now drawing to a close, and I think we'll be reconvening in a few minutes for this afternoon session. Thank you.
We now move to agenda item 9, panel discussion on communication for health. Document WPR/RC73/5. I would now like to hand over to Dr. Achela Prat, WHO representative to Vietnam, to moderate the panel. Dr. Prat was until very recently the Executive Director of the Regional Director's Office and Director of the Communication for WHO in the region. Dr. Prat, over to you.
Thank you very much, Mr. Chairperson, distinguished representatives, ladies and gentlemen. I am delighted to introduce and moderate this panel discussion on communication for health in the Western Pacific region. And the reason I'm so delighted is simple, and that is because good communication can help us to do the job that each and every one of us is here to do, and that is improve people's health. Hence the term communication for health, or C4H for short. So C4H can play an essential role in addressing some of our most pressing health challenges. When used strategically based on evidence and science, communication can, for example, help to increase vaccination rates to protect children against infectious disease, or indeed to protect all of us against COVID-19. It can help motivate people to quit smoking. It can help nudge people towards eating healthier diets and exercising more. In short, C4H means ensuring that the right information in the right language, on the right platforms, and framed in the right way reaches the people who need it, especially including the most vulnerable and disadvantaged. Getting all of this right requires technical skills and knowledge, though communication has not always been recognised in public health as a technical field requiring specialist expertise. But since the adoption of the For the Future vision, we've been working in this region at least to change that by establishing C4H as a technical program in the region. So this technical work includes drawing on data and insights from social science to figure out the best strategies for informing and changing attitudes and behaviours, and we'll see some examples, some really terrific examples of that later in this session. It requires the skills to understand and respond to drivers of a particular health issue. It demands the capacity to use all of this information to connect with audiences, including through telling powerful stories that connect with people's hearts, not just their heads. All of this requires the expertise of a range of disciplines, the efforts and skills of a broad range of partners and multidisciplinary teams. We think we've made some good progress towards our vision of C4H becoming a fully fledged technical program in the region in the last couple of years, but we know we're not there yet. We also know that to fully harness the power of C4H, we need to keep working together to strengthen capacity and capability and to scale up application at country level. Last year, you might recall that C4H was featured as a side event at the regional committee. This year, we are absolutely thrilled that it is part of the main agenda, part of the main program. And we really hope that this panel discussion today will help us to take another step towards embedding C4H into the fabric of the support that we provide to all of you, to our member states in the region. So we're really looking forward to hearing directly from countries on the role and value of C4H in their context, their experiences in applying it to different health challenges. And through the dialogue and discussion that we hope to have today, we hope to keep working with all of you towards C4H, a shared vision of C4H as a tool for improving health in the region. So during today's panel discussion, we will hear from 4 countries, Malaysia, Australia, China, and Fiji, who will present quite a diverse set of examples of C4H in action. Our first keynote speaker is from Malaysia. I will introduce him properly in a moment, but first, just to set the scene, we're going to play a very short video to illustrate how Malaysia has made use of data, evidence, and behavioural science to increase the effectiveness of public health messages to encourage COVID-19 protective behaviours. So let's play the video now, please.
People make decisions based on many different factors, and these decisions ultimately affect our health. Understanding what influences human behavior is key to the effective design and implementation of communication, policies, and programs for health. This is where behavioral science, a key pillar of WHO's Communication for Health or C4H approach, plays an important role.
Behavioral science is actually the first line of defense for public healthcare. If you can get people to behave differently, to have health-seeking behavior, to go for their vaccinations, then this will tremendously strengthen everything else in the healthcare system.
As society-wide measures to control the spread of COVID-19 were eased in countries such as Malaysia, individuals needed to take responsibility in assessing their risk and taking actions to protect their health. New ways of communicating were needed to continue to engage audiences with trusted health advice, even as fatigue set in. WHO worked with the Ministry of Health to design communication messages and materials that were informed by data and evidence, and co-designed with the public through focus groups and interviews. These materials were taken to an online randomized controlled trial to test their effectiveness in encouraging key protective behaviors for COVID-19.
This work produced recommendations for the design, language, content, and process of developing new communication materials. The insights help us determine which materials work best to encourage people to form the protective behaviors for COVID-19, as well as to optimize future communication with the public.
When we use behavioral science, we can create targeted and people-centered communication strategies that ultimately lead to improved health outcomes.
Thank you very much, colleagues from Malaysia, for that excellent video of a really terrific example of C4H in action. So I'm now delighted to introduce our first keynote speaker, who is from Malaysia, the Honourable Khairi Jamaluddin, to tell us a little bit more about this work. Honourable Minister, you're a brilliant advocate for the use, in particular, of behavioural science in this area and across other communication strategies. So we are delighted to have you here in Manila with us, and the floor is yours.
Thank you. Thank you very much, Angela, Mr. Chair, ladies and gentlemen. I have a presentation that will guide the discussion. Thanks. Next. So behavioral science as a component of communication for health is very important. It gives us the insights, the data, and the evidence for us to develop communication strategies, tools, in order to nudge people in behaving a certain way. And of course, during the pandemic, this was essential in getting people to stay at home, wear their masks, check in, and also get their vaccinations. It was a combination, of course, mandates, but we felt it was important as we transition towards endemicity, that we relied less on legal mandates and more on community solidarity, social norms, and individual responsibility, and how communications encouraged people to do that voluntarily. Next. Of course, crises are outliers. It's very, it's easier to get people to do things during a crisis. We had 1 million people taking the AstraZeneca jab at a time where there were concerns about it having unintended thrombosis events or blood clotting events. But people signed up for it because it was a crisis. Now, of course, it's very difficult to get people to behave in a certain way when you transition towards more normal circumstances. So, for instance, in Malaysia, our adult COVID-19 vaccination rate for 2 doses is 98%. But for the second booster dose, i.e. the 4th dose, it's only 2.2%. And that's because people don't see it as a crisis anymore. Next. Of course, there was near compliance during the crisis because of simply because it was life or death for many people. It was easier to get people to nudge people to do certain things. But norms which are outside of a crisis environment, difficult to change. For instance, smoking. We have a ban on smoking in public places. And unfortunately, we have to fine people because social norms have not really taken root when it comes to things which are not in a crisis environment. Next. We also have to accept that health officials can no longer count on being in a spotlight. It was easier to nudge people during a crisis simply because everything that was said by the Ministry of Health had a lot of virality, people sharing it simply because of the single source of health authority. Of course, these halcyon days are gone. Now we compete with other things which are back in the spotlight post-pandemic. Next. But we need to move beyond the pandemic and see how we can use the lessons from behavioral science and communication to ensure that we can tackle issues that go beyond the pandemic. And we come back to, for instance, the NCD epidemic that affects so many countries in the region. So during the vaccination registration process, we had a survey. People had to register their comorbidities. So for instance, you have alarming rates of senior citizens who registered comorbidities, just driving the point home that we need to deal with this post-COVID. Next. And of course, aging population with a high NCD rate, this is a real challenge. So we've really thought about how to apply behavioral science, the lessons from COVID, some of the principles in tackling this going forward. Next. One factor that I want to highlight, and I'll come back to it right at the end of my presentation, is that more than half of determinants of health are due to social and economic factors outside of the healthcare system. And this is important to recognize because simply by nudging towards better behavior or healthier behavior and health-seeking behavior alone will not succeed if we do not take into account SDH, social determinants or socioeconomic determinants of health. In a vacuum, C4H and behavioral science will not succeed if we're not aware of the underlying factors. Next. So for instance, data from Malaysia suggests that about 33% of the B40, the bottom 40 income earners, are detected with NCDs. This tracks with evidence from around the world saying that people who are less off are worse off in terms of the health outcomes. And of course, COVID-19 exacerbated and exposed these inequalities. Next. What we want to do is behavioral change, not through explicit nudges, but more towards community empowerment. We found that being together and creating a social norm was more important than just individual nudges. So in our transition towards endemicity, there was a huge focus on saying that, look, it's a social norm now for you to decide your risk assessment, wearing a mask, not wearing a mask, whether to attend a busy event or crowded event, and creating that empowerment around a community, being part of a community, being part of deciding on a social norm was very, very important for us. Next. So just one case study, coming back to the NCDs after COVID, we have a free health screening program, in which almost 6 million Malaysians are eligible for a free comprehensive screening program. Unfortunately, only 12% of eligible beneficiaries have been screened. And this is free, completely free. All they need to do is go to a designated clinic and they can get screened. Next. So we've tried to study why. Why is the uptake low? Try to understand the behavior behind this and try to understand what communications are needed to do so. One, of course, is the lack of health-seeking behavior amongst the particular group of people who are eligible, the B40 community. Insufficient awareness and promotions in targeting that community. We found that the communications was just too complicated. A lot of it was not in vernacular language. A lot of it was not accessible. And of course, they were reluctant to go due to the COVID-19 pandemic, in which, as I said earlier, inequalities were exacerbated. They were thinking about livelihoods. They were not thinking about getting their health screening. Next. So we looked at our history of behavioral science and practice in Malaysia, and we realized that we've moved away from disease-based towards more, as I said earlier, intervention, empowerment, and now social capital, getting people to own their health, and also a social norm around this. Next. So what we decided to do was to create a social movement around living a healthy life or healthy living among Malaysians with 3 pillars, which is predisposing, enabling, and reinforcing. Predisposing is basically understanding, appraising the local context, understanding why people are not living healthily. Is it because of SDH, social determinants? Is it because of accessibility? Is it because of education? Is it because of understanding communications? Enabling, after we understand the predisposition, which is to make it easier for people to change the behaviors environment. It's one thing to lecture people to live healthy, to eat more nutritious food when they simply can't afford it, when it's much cheaper to buy fast food or processed food for their children, or more convenient. By not providing those the availability of these things, it's difficult for them to do so. And then reinforcing, rewarding that behavior, making sure that the behavior is sustainable, making sure that it's not a one-hit wonder, and making sure that you can sustain a culture of living healthy through nudges. Next. So we created a whole bunch of initiatives under predisposition, enabling, reinforcing to ensure that we can drive this. And it's called Agenda Nasional Malaysia Sehat, which is basically the National Malaysia Healthy Living Agenda. By understanding the local context, understanding what the obstacles are, enabling them by making it an actionable item for them and making it easier for them to act on it. And of course, reinforcing it through rewards, through incentives, and through very, very detailed monitoring by the Ministry of Health. Next. Now, we know that aggressive communication is important through various media channels. And I think this is a point that I think we need to stress extremely. It's important to stress, which is we really need to push the message out on multiple platforms. And now these platforms are a plethora of these platforms, and I can't stress enough how it's important for us, not just traditional media, mainstream media, electronic media, social media, just basically flood the media with the communications. And secondly, just as important is the ground engagement. It's not enough to put things up on the media. It's also very important to do it in real life. It's not just Facebook, it's face-to-face. And you need both approaches for you to succeed in terms of communications. Next. So for our health screening initiative, so when we transitioning out of COVID, we decided that we wanted to make sure that at least 1.5 Malaysians go through the national health screening by the end of this year. We realized that there was a small baseline during COVID simply because people didn't go for their health screening. We wanted to make sure that we caught up with a new baseline of where we are in terms of NCD. So one, we need to wake up the intentions. So the scary data was available to the Ministry of Health, and we needed to post that and tell the public, look, we have an increasing burden of NCDs post-COVID, and we need to do something about it. Second, to bridge those services, as I said, to make it easy for them, to make it actionable for them. So what we did was we repurposed our COVID app to become a national public health app. We pushed out not vaccination appointments, but rather health screening appointments, so that it's easy for them to just press a button and just go and attend. And of course, link this to the big picture, which is linking the data, using the data, the nudges towards keeping 10 million Malaysians healthy who would otherwise fall sick over the next 10 years. So our big picture is 10 million Malaysians stay healthy over the next 10 years by using the data. Next. But of course, we have challenges, and I want to walk through some of the challenges. One is our trust points are spent. We've told people how to behave during COVID, and now, of course, people don't want to listen to us anymore, and it becomes very difficult to nudge post-COVID. They're tired of the tech, they're tired of listening, they're tired of complying. You can see how there's a cliff, it plummets after I lifted the rules on checking in, on the QR code checking in. Everyone decided to ditch it. So now, next, and of course, too much data. The ugly side of digital health is that people are now scared of using it. They were willing to use it during a crisis, but now they are concerned about data breaches. They're concerned about insurance being rejected because private information may be leaked out about their health conditions, so that they are concerned. Next. So what do we need to do? One, we need to come back to the 3 pillars of communications and behavioral change. And this is what we do in Malaysia. One is clear messaging. Be very honest. Tell it like it is. And I'll give examples. If you can't sell it, don't say it. If you can't provide the context, don't condescend. Tell them honestly what we are confronted with. Second, actionable info. Tell them what to do or what they can do. Get personal. Give people a story of what happens when they go to the clinic, when they get tested. Think of circumstances. Don't omit anybody. Make sure no one's left behind, like the vaccination. And third, design nudges that they like. Tell them like they like it. Know what gets people to move. Use it. Don't make it scary. Help people help themselves. As Angela said, Don't just speak to their minds, but speak to their hearts as well. And repeat this and turn healthcare goals into a national culture. Next. So, tell it like it is. Don't sugarcoat it. If you are confronted with a new wave, tell them a couple of days ago. I mean, our numbers are going up slightly. So I told the public, look, cases will rise. Don't be alarmed. It's under control. So always, always communicate clearly. Next. If you screw up, then tell them that, you've got it wrong and that you'll fix it. This is what our website registration for the vaccination. It crashed on the first day, obviously. So own up to it, own it, and apologize and say, we're going to do better, because the moment you lose credibility, it's very difficult for you to reclaim it. Next. Actionable info is very important. So when COVID flared up in schools, after we opened schools, it was important that we got parents to do self-tests and reported the self-test. Some people did tests and they didn't report the test. So what we did was just create a simple, actionable infographic and blasted it all over social media and mainstream media. The same day, report rates started to rise. Never, ever underestimate instructions that are clear and concise. They make a big difference, because instructions lead to action, and action leads to, of course, behavioral change. Next. And tell them like they like it. So many of us have done this. We tried to figure out how best to vaccinate our people when vaccination rates were low. In Malaysia, of course, we did it at places of worship, mosques. We got our imams to do it first. And of course, speaking to their hearts. When the imam does it, when you do it at a mosque, it's much, much more acceptable to a segment of the population than if it's done in some cold convention center where they have to go for their vaccination. Next. And of course, nudges. And nudges, we don't really nudge with a sharp elbow. We tend to nudge softly. It's very important not to get nudges into people's faces. So for instance, we had Paxlovid. So after a while, Dr. Tedros always speaks about all the tools that we have to fight COVID, the vaccinations, antiviral. So we got Paxlovid. And Paxlovid, the uptake was very low at first. So we decided, why don't we send out just a subtle text? So the text is on the bottom left. What it basically says is, you may be qualified, you may qualify for having Paxlovid treatment, rather than go for your Paxlovid treatment now. And that immediately increased the number of uptake for Paxlovid, as people said, okay, maybe I qualify for Paxlovid, maybe I'm high risk, maybe I should go for the antiviral treatment. And of course, we made a lot of things online, made it easy. So we transitioned our COVID app to a public health app, as I mentioned earlier, not just Paxlovid, but organ donation, blood donation. And it's amazing, because once we put organ donation onto the public health app, the increase in the number of organ donation pledges that we received through the app was higher than ever before in the history of Malaysia cumulatively. And just by putting it on the app, a subtle nudge saying that you can register as a pledger online. Next. And of course, solidarity is important. I come back to this. It's important to create a social norm. So as I mentioned earlier in my intervention, now we're trying to tackle smoking, to make sure that we can't have a legislation so that you can't sell cigarettes to people born after 2007. People are saying, how will that work? There's black market. But my contention is that if you have a social norm, if you have a national solidarity, everyone after 2007 says, well, we're part of a smoke-free generation. We're not supposed to smoke. Then that creates the incentives and the behavior for people of that generation to be part of that social norm and saying, look, we just don't smoke anymore because we're born after 2007. So create it into a culture, into national solidarity, and the behaviors will change. Next. And then, of course, this is expanding the existing technology, which I mentioned earlier, transitioning the app and becoming something that is useful to people and actionable for people. Next. And always, always, always be transparent. So what I did with a COVID website, in which we line listed anonymously every single COVID case with every single vaccination given, was now we transformed it into a transparent repository, open data, open source for anyone to access about anything to do with the Ministry of Health, whether it's infectious disease, whether it's blood donation, bed utilization, organ donation. Now you can check by hospital, what the blood bank, blood type, or everything. So basically, be as transparent as possible if you want people to believe in your nudges. Next, and apart from the behavioral science for better health resolution that we're proposing at the World Health Assembly, we've also set up a insights unit, behavioral insights unit, which is directed towards projects in screening, behavioral tools, blood donation, etc. Next, 2 more slides. How can we work efficiently? Now, this is the caveat that I want to say. Nudges can only work if social and economic conditions are conducive and health systems are resilient with sufficient investment. Next, behavioral science is not a silver bullet. It's only complementary if you have the necessary foundation in place. Thank you, Angela.
Thank you so much, Minister. You've touched on so many of the fundamental points of the C4H approach in your intervention. I'm going to come back to you a little bit later with a couple of questions. But first, we want to turn to a different part of the region, Australia, a country that has extensive experience in rolling out communication campaigns. In fact, picking up on a couple of your points, Minister, as part of a comprehensive policy approach. And campaigns that are about increasing public awareness, changing mindsets, encouraging healthier behaviours. So our second keynote speaker is the Honourable Minister for Health and Aged Care of Australia, Mark Butler. Minister Butler is unable to join us in real time today. It's a very busy day in Canberra. The new government is handing down its first budget tonight, but he did prepare a really excellent video message to tell us about Australia's experience in using communication as part of a comprehensive approach to tobacco control. So we're going to take a look at that video now, please.
Well, thank you for the invitation to be part of this panel discussion on the topic of communication for health. I'm speaking to you from Parliament House in Canberra on Ngunnawal country. I acknowledge all First Nations people of Australia and extend my respect to them as the traditional owners of this land, to their elders past, present and emerging. I also celebrate and honour their status as the longest continuing culture in the world. I want to thank the Western Pacific Regional Office for its important work on non-communicable diseases to date, in particular its efforts in improving tobacco control in our region. I appreciate the opportunity to speak to member states from the Western Pacific region about Australia's communication campaigns in tobacco control. Australians, just like people right around the globe, want to lead healthy and fulfilled lives. We know that governments taking a proactive role in health promotion can help them achieve this. In Australia, we ensure that research and evidence underpin and guide communication campaign direction and design, and we follow up with proper evaluation of impact and of effectiveness. The value of health communication is best seen when it delivers real benefits in public health. Australia has extensive experience in tobacco control, and over the years, significant gains have been made in this important area. Back in 1990, tobacco smoking rates were around 28% of our entire population. Today, I'm pleased to say that that rate is down to just 11%, but still more than 2 million Australian adults smoke. We're focused on the increasing number of smokers who use both tobacco and e-cigarettes or other vaping products. Communication has been a part of our comprehensive tobacco control program for years. There's really strong evidence that tobacco control campaigns are one of the most cost-effective and influential strategies for adult and youth tobacco use. In fact, campaigns are second only to price increases in overall impact. In Australia, mass media campaigns run alongside education programs, tobacco packaging and labelling measures. Australia takes great pride in its world-leading tobacco plain packaging reforms, speaking from my own experience as a junior health minister in the government which introduced this policy. Plain packaging discourages tobacco use by reducing the appeal of products like cigarettes, improving the effectiveness of health warnings, and removing potentially misleading information from the packaging. When this reform was introduced back in 2011, the government persisted, despite legal attacks, to oppose this measure. Communications backed in the policy change and pushed for greater behaviour change as well. In the years since these tobacco plain packaging reforms and the significant population-level campaign activity at that time, Australia has taken a targeted approach to campaign development and to campaign delivery. We've focused on priority population groups with higher smoking rates, They include pregnant women and their partners, as well as First Nations communities. The most recent phase of the National Tobacco Campaign ran between 2016 and 2018. The Don't Make Smokes Your Story campaign had really strong results amongst First Nations communities and, interestingly, also had significant crossover appeal with non-Indigenous smokers. In Australia, the unique considerations of our First Nations communities, including the need for culturally tailored and co-designed communications, is recognised with ongoing commitment and funding towards the Tackling Indigenous Smoking program. That program's activities include locally tailored communication education campaigns, social media and social marketing activities, and a range of communication-based activities including radio and television advertising, smoke-free messaging on merchandise, and promotional activities such as branded smoke-free events and spaces. Independent evaluations have praised the TIS program as internationally renowned, efficient, effective, culturally appropriate, and co-designed with First Nations people. Our national and subnational governments, along with the public health sector, play a significant role in delivering tobacco control campaigns, and collaboration is vital in the national effort to minimise smoking-induced harm. A comprehensive consumer research program is currently underway to inform the strategic direction, design and delivery of future phases of our tobacco control campaign activity. The government is examining a range of tobacco control measures which are supported by evidence and focus on both the supply of and demand for tobacco, consistent with our obligations as a party to the WHO Framework Convention on Tobacco Control. Work is underway on Australia's next tobacco strategy, building on historic successes and strengthening that collaboration. Our government is invested in the health of all Australians, and we recognise that public messaging and communication campaigns have a significant role in bringing our population along with us. Health communication does not occur in a vacuum, but when properly informed, researched and targeted, it can and does deliver real goals. And when those goals improve health outcomes, everyone wins. I hope that some of these insights into the Australian experience of some of our health communication challenges and successes might be useful as you explore this topic today. I wish you well with your conference deliberations.
Very useful. Thank you, Minister Butler, and thanks colleagues from Australia for facilitating that contribution, which again touched on so many of the really critical aspects of C4H, the importance of underpinning communication design with research and evidence, the importance of ensuring that approaches are locally tailored and targeted to the audience, co-designed with the community, collaboration with partners and stakeholders, and of course, the vital role of evaluation, which shows the impact that a well-designed and well-crafted communication campaign can have. So from Canberra, we now go to Beijing to our next guest speaker, and I'm delighted to introduce an example of some work that we've done in China in collaboration with the government and some academic partners at Tsinghua University, where C4H principles were used to study the effect of different communication approaches in nudging consumers towards making lower sodium food choices. So before I introduce our guest speaker, we're going to again share a short video to set the scene, presentation that in fact has been years of work in the making. So let's play the video now before I introduce our guest speaker, please.
Most people in China eat too much salt. Salt is the main source of sodium in people's diets. And too much sodium is a major risk factor for high blood pressure, heart disease, and stroke. 270 million adults in China have high blood pressure, and cardiovascular disease is the #1 cause of death in the country. To address this challenge, WHO worked with the National Institute for Nutrition and Health, China CDC, and Tsinghua University, with the support of Resolve to Save Lives, to launch a communication for health intervention. The C4H approach uses behavioral insights, drawing on evidence about how people behave, and testing which strategies are most effective in nudging them towards healthier behaviors. The team partnered with an online food delivery platform to study the effectiveness of different types of communication interventions for changing people's food ordering behavior. And the interventions included testing the effectiveness of conventional educational health messages and the behavioral science-powered nudges, such as changes to the choice architecture in the online platform. Results showed that a health message alone was not effective. However, a sub-menu of options for regular salt and reduced salt prompted consumers to select healthier options. Insights from the trial will inform health promotion strategies and policy recommendations for improving health and reducing the burden of non-communicable disease in China and our region.
So thank you very much, colleagues from China, for the video. And to tell us more about this work, I'm now delighted to be able to introduce Professor Gangqiang Ding, who is the Director of the National Institute for Nutrition and Health at China CDC, our partner in this work, who's joining us virtually from Beijing today. So Professor Ding, as we've just seen in the video, this work was not a traditional approach to health communication. Tell us a little bit more about the insights from this work. Over to you. Please go ahead, Professor Ding.
谢谢主持人。大家好，的确，正像刚才视频当中所介绍。
Thank you, Madam Moderator. Good afternoon, everyone. As introduced by the video, this Communication for Health program has used breakthrough and innovative education and dissemination method. We use the behavior nudges. So in those food order platforms, we have introduced some menus with a lower intake of salt. It is a low-cost, innovative strategy, but has been effective in encouraging the consumers to select less salty diets. And this has provided us with a great guidance and reference for reducing the salt uptake among the general population. It gives me great pleasure to share with you China's innovation in the reduction of salt consumption. This program was initiated and supported by the WHO China Country Office. The Nutrition Research Institute of CDC collaborated with the City Urban Testing Lab of the Tsinghua University, and in 2020 and 2021, we started with this program of the salt uptake reduction, one of the food ordering platform, which is called Are You Hungry? This is a very popular food and fast food and delivery food ordering platform. To promote the effectiveness of this program, we used the food ordering platform. We have basically three mirrors. First, on those menus, we set up some of the dissemination information tips. The less than 5 gram salt intake for a healthy diet and a healthy diet among the adults, as recommended by WHO. Second, we have the secondary menu nudges to the consumers so as to provide less or normal salt intake for the consumers. And third, we have a default menu. In the secondary menu, most of the menus and dishes promoted on the platform have a less or normal salt consumption. So with these mirrors, we set up 5 groups of intervention and 5 in comparison as the random comparison control group. This program was initiated in August 2020, and in 2021, July, we started with the actual implementation. We've recruited some of the restaurants to join us. We've guided them to design their menu interfaces. The Tsinghua University team on a weekly basis has been examining the implementation of the program, and our Nutrition Research Institute of CDC has provided the merchants with the education pamphlets. For 2 months in a row, we conducted random checks to test and monitor the salt containment in the dishes, and afterwards we collected data from the implementation of the program. We have conducted the data analysis on multiple dimensions, and we've noticed that in the intervened group, there has been a substantial decrease of the salt consumption. Without the intervention measures, the consumers tend to select dishes with a higher salt consumption. Only 1% of the consumers would prefer to write something on the remarks. But the intervened group, we found that 40% of the consumers have left remarks that they want less salty dishes. Most of the restaurants have shown the willingness to cater to the needs of the consumers for a reduction of salt intake. Data results analysis has shown that with the proper intervention measures, there has been substantial decrease of the salt intake among consumers. With these positive results, we have the confidence to believe that with the behavior nudges and the behavior intervention have been proven effective in reducing the salt intake among consumers. At the same time, we've noticed that though consumers have the need and the willingness to have a reduced salt intake, and the restaurants have the willingness to cooperate with us, we still feel that the processes and the channels are still a little bit clogged. We need to keep the channels and processes unclogged and unimpeded, and we need to roll out these behavior changes across the bigger platforms. Research institutes and the governments should all be involved to play a better role. That's why I find today's panel discussion coming at the opportune time. Thank you. That's my sharing.
Professor Ding, that was really excellent, and I think a terrific example of the amount of work that goes into getting this soft elbow nudge, right? I think that's what you called it earlier, Minister. So thank you very much, Professor Ding, for being here. We'll come back to you a little bit later for another question, but first we want to hear one more example, this time from Fiji. I think we had some technical difficulties connecting our guest speaker from Fiji. We're going to check if she's online in a moment. While we're doing that, we have prepared another short video again to demonstrate an example of how the country designed targeted, people-centered communication interventions for COVID-19 by listening to the community first. Sometimes we think communication is all about the talking, but actually it starts with doing really good listening. So we've got an example of this from Fiji. Let's take a look at the video before we check if our speaker is online. Let's play the video, please.
Each day, people seek out, share, and are exposed to huge volumes of information. And with the growing presence of online and social media, the ways that people communicate and access health information continues to change. With this great volume and speed of information exchange, how can health authorities know what information people are sharing and whether it's helpful or harmful to health? How can they know what people think about a health issue, what concerns they have, and the health advice they need? Social listening is the systematic collection, filtering, and monitoring of public discourse across different channels and platforms, both offline and online, to inform communication strategies and improve service delivery. In Fiji, the Ministry of Health and Medical Services, together with WHO and partners, used social listening to draw insights into the public's sentiments and actions around COVID-19. One thing they found was that some people were not going to the hospital for COVID-19 treatment because of a fear of isolation and concerns over the quality of care. In response, the ministry, with WHO's support, launched a 3-part campaign to restore people's trust in the healthcare system. The campaign responded to the community's questions and concerns and featured stories of nurses and testimonies of patients treated for COVID-19. The personal stories resonated with audiences, and importantly, more people sought treatment for COVID-19 and other conditions. Fiji's social listening system has continued to inform the country's COVID-19 response, and as a result, lives have been saved.
thank you so much again to our colleagues from Fiji for this video. I'm delighted to welcome our panelist now from Fiji. I really hope she's online. She's joining us virtually from Suva today. That's Dr. Anasani Masema, who is the General Manager for Fiji's COVID-19 Incident Management Team. Dr. Masema, I see that. It's so great to have you with us. Thank you for joining us. Could you tell us a little bit more about why it was so important to the country's COVID response to establish such a strong listening system? And how did some of the signals that you picked up through that listening lead to adjustments or changes in the COVID response? Over to you.
All right, thank you. And Bola Vinaka, ladies and gentlemen, it's just a short presentation of how we use social listening especially during our Delta response, and a lot of learnings as we went through the Omicron wave. Next slide, please. So, a lot of you will probably know what the story about our COVID outbreak. So it was 365 days since our local case in April 18th when we had our first our local Delta case. So we was announced by the Prime Minister that we were marking the 1 year and also announcing the latest case. And we went through responses like any other country, containment. We were really getting overwhelmed, and we switched to mitigation, where we really concentrated on our vulnerables. We were in this transition for quite a while before we went to community suppression, and to date we're still in that phase. We're really learning to live with the disease, but now varieties of that phase. And then you can see our numbers, and on the side you can see just the waves, our epic curves since the Delta wave, and our admissions, and also our severe cases and our critical cases, which really mimics the epic curve. Next slide, please. All right, so with RISCOMS and community engagement, we were very lucky because we had an RISCOMS and community engagement technical working group, which was reactivated in 2021, around March to April. They really were in contact and really coordinating with the comms pillar in the incident management team. So we coordinated the response. There were 7 pillars, including the comms team. And in the RCCE pillar, in the RCCE technical group, we had the Australian, the HICOM support comms officers. We had WHO, UNICEF, South Pacific Community, Red Cross, and including the information department in Fiji. And so what happened was on a daily basis, we provided updates on the transmission and issues from within the vaccination space. And that really became action-oriented meetings and coordinated a lot of efforts that led to harmonized communication and course correction. So, so there were a lot of well-designed, targeted products, comms products that were produced through media tiles, radio talks in 3 different languages. We had videos and messages that also went in 3 different language. We had targeted webinar groups, and also these were produced in real time to address the needs, and they were very quick turnaround time. Next slide, please. So, how did we just leveraging social listening to shape communication and supporting especially vaccination and our other response strategies, different arms of our response. So the social listening was a subgroup of the RCCE group. And what happened was they gathered information online and offline. And you can see the list of sources that we use. So the government COVID line was the 158 number. They used the Talk Walker that monitored social listening, social media, the Meltwater that monitored the news portals. And then very important, the community feedbacks which came through the CSOs, the NGOs, and of course, mainstream media and social media. And We also included the feedbacks from the health workers and the frontliners who were engaging the community as they were conducting contact tracing. And this really came through on a daily basis when the divisional heads, the operational leads in the divisions were presenting during the national meetings. So all this information really informed the risk communications. And also, as it was fed back to IMT, it really helped to inform the operation. Next slide, please. So some of the examples of how social listening really shifted some of our programs. So one example is the decentralization of vaccination sites and further outreach. We realized there were three things we picked up from social listening. So one was there were difficult. The people were facing difficulties in accessing the sites, really due to distance and the inconvenience working out the operational hours. The second was just fear of the crowded vaccination centers. And then the third was that older people and persons living with disabilities had difficulty in accessing the walk out, just to walk into clinics. So what led to that was, next please. Was really, that's when we decided very fast to set up drive-through vaccination sites, and then really just making sure that all our sites were inclusive of the community. We also had stationary sites. We had mobiles teams who were really addressing those that needed people asked to come to closer to their communities. Next slide, please. So the second example is, how did we look after our pregnant moms and making sure that they were getting vaccinated. So again, through social listening, what we picked up was the pregnant women were very uneasy about visiting vaccination site in fear of exposure to the virus. And we knew that they had to come to our hospitals or at least our facilities where the service was provided for their clinics. So really what led to that, and again, just a next please. What really led to that information was we then informed the obstetric team, the obstetric lead, if we could start vaccinating the moms as they accessed the facilities, because we pushed the ANC clinics out. So to get them vaccinated as they were coming for their ANC clinics. Next slide, please. So that's really just that led to those actions like I've mentioned. So these were operationalized. We had multiple sites just for pregnant women as they were coming in for their clinic. Next slide, please. And the third one, when it comes to vaccination, was just really reaching people living with disabilities. We tried to make sure through communications with the CSOs to include really inclusive approaches to disseminating messages. A good example was we collaborated, the RCCE team, they collaborated with the Fiji Disability Forum to ensure that the vaccination was made accessible to everyone. So as they were reaching out to their members, they were feeding information, and then we really made sure we were implementing some of those things into our responses just to make sure that everyone was getting accessible to our sites. Next slide, please. Right. So the other really important part of our response that was assisted by social listening was the implementation of the care flow pathway, where we, during the mitigation phase on the last end of our containment phase and mitigation phase, this was really instrumental in the decrease in fatality. We all know there's a lag between cases and deaths, and by July we were hitting thousands of cases. And we noted in our deaths that 70% of our deaths our deaths were increasing, were really occurring at home en route, or on the first day of admission, which means they just came in too sick. So the question was whether it was accessibility and confidence. So really, and again, the care flow pathway included the vulnerable follow-up, the toll-free line, the pre-hospital emergency care coordination cell, setting up isolation wards and intermediate care facilities, and making sure that they were functional sites. So social listening gave us an indication of public reaction to the efficiency of these services, which was fed back to the national brief and allowed us to expand all components of these pathways. So we really managed to expand very fast. We looked after our vulnerable very well, and that led to the decrease in the deaths. Next slide, please. So really, social listening helped to address a lot of demands for information during COVID-19, during the vaccination campaign, and definitely other aspects of our response, which really led to the RCC group improving and adapting as we moved. And again, it led to a lot of information, nuancing this information, and as they were disseminated through multiple platforms. So this was a two-way communication. And then through that, we really managed to identify whether it was misinformation and disinformation, or really just so making sure we were addressing those as we were going through, and then really helped us to identify the community perception and helped us to inform the planning of targeting our community. Next slide, please. So those really are just pictures, of what we had to do with changing our ways of engaging and responding. And you can see there we've got a good. The eastern part is surrounded by the sea. So that's just some pictures depicting of what I just mentioned. Next slide, please. So, how do you fortify trust during an emergency? And like any virtue, it takes time to get our audience to trust us. So we needed a Ministry of Health spokesperson. And as you all know, the permanent secretary for Ministry of Health and Medical Services, Dr. James Fong, was the designated person. Next, please. So he played a crucial role in building trust and confidence in the people. Next, please. And one of the main reasons, when you talk to people, was, they said it was just very easy. He did his speeches every day, just using very easy to understand language that really resonated with people. So it really ensuring and critical to people receiving and understanding information and the dynamics of what was going on and how it was evolving, the COVID outbreak. Next, please. So really the key achievements for our RCCE group in terms of social listening, we really work together as a group to translate our Ministry of Health protocols into user-friendly language and visuals that was well accepted by the general public, and it was most up-to-date and accurate information. And also social listening definitely supported better understanding of the community perceptions and their concerns, which really helped us plan our activities. And then, of course, Dr. Fong really played that critical role in building the trust and confidence amongst the general public. Next slide. So that's it from Fiji, Vinakavale, and happy Diwali. We are celebrating Diwali today. Thank you.
Thank you so much, Dr. Masema, colleagues, partners in Fiji. Really terrific example of how listening informed actually not just a change or an adjustment in the communication strategy, but in the actual response itself, the focus of the response, the activities. So thank you so much for sharing. I am going to come back to you for a question in a little bit, but in fact, I want to just go back to each of our panelists joining us live today for one question before we wrap up the panel part of the discussion. So I want to start with Minister Kari, who's here in the room with us. Minister, you are such a brilliant advocate for strategic communication and for behavioural science.
And we saw in your presentation how you kind of started with COVID-19, but you've expanded that or are expanding the use of behavioural science to a range of other areas. So my question, two-part question, what drives that personal passion? And tell us a little bit more about how you'd plan to take this forward, the application of behavioural science forward beyond COVID-19 into the future.
Thanks. Thank you, Angela. What drives this? I think what drives this is simply because if you look at, when I go down to the ground, to the hospitals and clinics, and I do this regularly, sometimes unannounced, and I speak to the doctors and the medical officers and the nurses in the wards, and I ask them what kinds of cases are being admitted. More than 70, 80% are cases which are avoidable. Complications due to non-communicable disease, diabetes, high blood pressure. And in many, many cases, these cases should not be congesting our hospital. We should move healthcare towards primary care, community and individual responsibility. And having said that, it's very, very important that we tackle the issue of behavior. If we can't nudge people into behavior that is health-seeking, that is more healthy, then we will be overwhelmed by the NCD cases in the years to come with an aging population. So that's really what drives me, because I see that if you don't tackle it at its source, then it will get out of hand very, very soon, and we won't have enough financing to care for those people who are sick. How do we take it forward? And as I said earlier, it's one thing trying to identify that behavior is at the source of the problem, but it's another thing to understand that human behavior is not just made up of individual choices and nudges. It's also informed by the environment that they're in. Sometimes they want to behave differently, but they're not able to do so. So behavioral science, communication for health, must be combined with a serious agenda into tackling social determinants for health. I don't think people choose to deliberately not live healthier lives. I think they want to, if they can. So you must remove the obstacles in the way for them to live better and for them to have health-seeking and health-maintaining behavior. And as I said earlier, if you don't tackle issues like poverty, housing, accessibility to nutritious food, climate change, environmental cleanliness, sanitation, and just blame the individual for not wanting to choose to live healthier lives despite your nudges, then it's not going to work. So I'm driven by the fact that I know that this is the root cause, but at the same time, if you do communications and nudges in behavioral science in a vacuum without looking at the obstacles and making it easier for people to actionable outcomes for them to change their behavior, then it's not going to succeed. So it's complementary.
Thank you so much, Minister. I want to go back to Professor Ding to just follow up on the excellent intervention earlier, an explanation earlier about the sodium reduction work in China. So Professor Ding, we saw in the project that you highlighted the communication interventions which applied behavioral insights, nudge theory, did lead to a reduction in salt intake among consumers. So my question is, with such positive results, what is your vision for how this work might go forward? And can you see implications or recommendations for action beyond sodium reduction? Over to you.
谢谢主持人。
Thank you, Madam Moderator. As I have mentioned in my sharing, when conditions allow, we are more than willing to see the outcomes of this program can be rolled out in a bigger population to reduce the intake of sodium. As you have seen in my presentation, China has the highest sodium intake among all the Asian countries. If we can translate this study into actual results in reality, will have better achievements. Of course, it will be very challenging. For example, when conducting recruitment in restaurants, we need to mobilize the takeaway platforms resources and China CDC's internal resources. And the restaurants recruited are only accounted for 10% of those signing up. That is to say, a lot of the restaurants are not willing to undertake additional work. At the same time, we hope that by having the government taking a leading role, more influential partners can come in. We hope that the low sodium option can be a default option. And from the perspective of rolling out, we hope that the issue is how this low salt option menu can be more accessible. This idea is not impossible. First, there is no technological barrier. For example, milk tea is a popular drink among young Chinese, and this population is also sensitive to sugar and energy intake. Young people are also paying more attention to healthy diet. Therefore, many milk tea shops have applied the sub-menu to provide consumers with the choice of sweetness to the drink menu, although the default option is not necessarily no sugar or less sugar. However, it shows that the sub-menu is possible for wider promotion. So long as we work together, we work hard, we just need to think further and apply this effective measure to the work to reduce the intake of salt, oil, and sugar. I'm sure that will be very effective. Of course, nudging can also be applied to other settings beyond MDAs to promote healthier diet. For example, we can make changes to supermarket shelves to place water and sugar-free drinks and packaged foods with less salt, less sugar, less fat at eye level to increase the chance for consumers to pick up the healthier options. There will be bigger chance that they choose less salt, sugar, and fat. Thank you.
Thank you very, very much. Before we wrap up, I want to go back to Fiji, to Dr. Masema. Dr. Masema, you mentioned in your presentation that one of the strategies you adopted in response to what you were hearing, some of the concerns you were hearing from the community, was telling personal stories of healthcare workers, patients. Could you just give us a little bit more on why you chose that strategy? Why the personal stories, and what impact did it have? What did you see from that?
All right. So I do have an example of some of the stories. So we did when our deaths started to increase, and we received the feedbacks from our FAC, our pre-hospital emergency coordination cell group, and they were the retrieval team who were going to the community when we were receiving calls because people were getting a bit too sick. And when they were retrieving those that had succumbed to COVID-19, we asked them questions like, what was the story? Again, is it the confidence? Because we realized that a lot of these individuals lived within the SUVA boundary. So it's not accessibility shouldn't have been an issue. And some of the stories they said was from the patients, the family was, they were well, they were a bit just getting progressively weak, and then all of a sudden shortness of breath, and then they just collapsed. Then again, through a very close friend from the health workers, they realized that through an experience of one of the doctors, they saw their family members. They didn't complain of SOB. The doctor noticed that the family member was getting SOB, just recognizing that the family member was stacking 4 pillows and sitting up and sleeping. And as doctors, that's a clear sign of shortness of breath. So in the public were really waiting for the shortness of breath. So then the message changed, and we could see also that a lot of people, so the message changed to really driving progressive weakness and difficulty in breathing rather than shortness in breath, and the others in our comms. And I think the last one was a lot of people refused to come to the hospital because they didn't want to die alone. So at some point very early on during our, when we were looking after severe cases, we allowed family to join the severe cases. We had a criteria. We had 40, just 40 or less than 40 fully vaccinated to make sure that there was somebody sitting in there, or even just just recovered from COVID-19. So again, very important to listen to your team who are really accessing the people, getting in issues and listening to them, and really learning and evolving your response. So that's really just a personal story from us. Thank you.
Thank you so much, Dr. Masema, and a really good point to end the panel discussion on the importance of listening and empathetic listening as part of our work. Thank you so much to all of our panelists, Minister Khairi from Malaysia, Minister Butler from Australia, Professor Ding from China, and again, Dr. Masema from Fiji. It's been so great to have you with us, to hear from all of you about these brilliant examples of C4H in action from all of your countries. We are so excited about the possibilities and the potential of this work with all of you, and we really look forward to continuing it together and scaling up, we hope, for even bigger impact. So, Mr. Chair, that concludes the panel discussion portion of this agenda item, and I now hand the floor back to you.
Thank you very much, Dr. Pratt, and all of the panelists. We will have now our coffee break, and we will be back at 15:45 to this room. Thank you. We will now have intervention on panel discussion of the communication for health. Please raise your hands or who wish to speak. Click the button on your microphone. So the next speaker is Philippines. The floor is yours, Philippines.
I was supposed to speak. Okay. Question start now? Okay.
Good afternoon. Thank you, Chair. The pandemic highlighted the value of timely and accurate information in managing health crisis. We are affirmed by the excellent speakers a while ago on our work on behavioral insights, not just social listening, and even adding FSL in all our materials. And we are affirmed in that we are in the right direction, and thus our work also needs to be institutionalized. Further, more investments need to go into this area of work, and that the institution needs to continuously invest in human resources to do C4H work. Considering that in the Philippines, data continue to show that mass media, specifically news shows, were still the top source of information for the population, we sought to improve the quality of science reporting through systematic capacity building of our media practitioners in covering COVID-19 news and now even in other public health news, both at the national and local level. This is particularly useful in reporting of adverse events, tobacco reporting, as well as suicide portrayal in media. We complemented this by training even our external medical advisors to face the media and proactively book them media spots to cover as many TV and radio programs. Also, we held a series of town halls to continuously capacitate our community health workers. With our country recognized as the social media capital of the world, we of course optimize limited resources by using digital platforms extensively. We had, apart from Facebook, Viber, website, we also put out a chatbot that serves to answer questions from the population. We also partnered with leading social media companies on a Check the Facts campaign, which of course fact-checks misleading health-related posts submitted by citizens and expedites action to correct or remove this from circulation. Overall, in terms of the campaign, the Philippines executed market segment-specific campaigns enabled through partnership with a consortium of private sector companies and advertisers. However, recognizing that communication has its limitation, efforts to nudge, incentivize, or disincentivize people were also employed to complement our communication efforts. We request that the WHO continue to assist member countries in systematically building capacity among health departments at the national and subnational level on communication for health, specifically on behavior insights work, as well as help us quickly scale up platforms that provide vetted, laymanized health information by perhaps sharing templates or content that can already be easily adapted by our websites or chatbots. Thank you very much, Chair.
Thank you, Philippines. The next speaker is Solomon Islands, to be followed by Japan. The floor is yours, Solomon Islands.
Thank you, Chair, for this opportunity. Health communication remains an integral component of our effort in achieving better health outcomes for our people. However, the COVID-19 pandemic, as well as experiences pre-COVID-19, have demonstrated the need for us to rethink of how we can better improve and effectively communicate to people to improve health literacy and trigger a change in behavior and attitudes. In Solomon Islands, health promotion officers, in their efforts to promote COVID-19 vaccines, were confronted with questions from faith-based groups that are non-health related, but more on their beliefs, including that COVID-19 vaccine was the biblical mark of the beast. Obviously, it was very difficult to nearly impossible for these health promotion officers to provide an appropriate response. However, they were fortunately aware that the faith group leaders had received a first jab. Thus, the group was instructed to consult their leaders as to why he had accepted the vaccine. So in our case, the Honorable Prime Minister was the first person to get the jab, and I was the second person to get the jab for the vaccination. In 2014, a small study involving focus groups, discussion held in one of our provinces, found that fathers choose to fish to earn an income instead of taking their children for routine immunization. These are two important examples that points to the need for better understanding of target audience to guide development of health communication strategies. Inclusiveness and involvement of all relevant stakeholders in health promotional activities, including design and development of messages. This will surely generate ownership. Health messaging now needs to go beyond health to incorporate other non-health benefits, as not all people value their health. Chair, I wish to also highlight here that with increased access to the internet, the Solomon Islands, like many other developing countries, are vulnerable to the vast amount of disinformation about health. This is sometimes promoted and advocated even by professionals within the medical fraternity. For Solomon Islands, such sentiments have contributed significantly to the slow uptake of COVID-19 vaccines. The need is greater than ever for doctors and other health workers, care workers, to become more skilled in health communication and promotion to improve efforts to promote good health. Chair, these are some of the points that I wish to highlight. Thank you very much.
Thank you, Solomon Islands. May I remind you that your intervention be short. The next speaker is Japan, to be followed by New Zealand. The floor is yours, Japan.
Thank you, Chair. We welcome the new initiative on communication for health by the Western Pacific Regional Office. In Japan, the Ministry of Health, Labor, and Welfare, as well as many local governments, provide information via major SNSs and also use various conventional channels such as workplace, schools, communities, mass media advertising, direct mails, and coupons to enhance health promotion. Regarding suicide prevention and mitigation of loneliness and isolation, individual consultation support by various organizations, including the ministry, utilizes online chat, SNS, and emails as new channels, in addition to telephone, so that each person can choose the media that suits their preference. Some local governments have introduced chatbots that can respond 24 hours a day to inquiries about health checkups and arrange appointments. We look forward to sharing innovative ideas from other countries and territories. I thank you.
Thank you, Japan. The next speaker is New Zealand, to be followed by Republic of Korea. The floor is your New Zealand.
Thank you, Chair. Tēnā koutou katoa. Aotearoa New Zealand thanks the esteemed panelists from Malaysia, Australia, China and Fiji for sharing their valuable insights around the communication for health approach with us today. As we have seen throughout the COVID-19 response, the way we communicate around public health needs to be informed by the communities we're working for and must constantly evolve to ensure we provide clear and credible information in easy to understand ways. Listening, learning and responding is key. Aotearoa New Zealand fully supports the C4H approach, and we acknowledge the significant role communications have in shaping individual and community decisions, particularly in the context of a public health emergency. At the outset of the COVID-19 pandemic, our strategy focused on ensuring information across all mainstream channels was reliable, up-to-date, accessible and relevant to all sectors of the population. This helped the public to stay well informed. But as our public health response to COVID-19 shifted, so too did the way we communicated for health. We engaged with trusted community influencers and leaders to produce communications with underserved communities, including Māori and Pacifica, and our campaigns became increasingly tailored for specific groups and populations. These actions supported a more equitable approach to communicating for health, and we plan to integrate them into our future responses to health emergencies. We know there is great potential to further strengthen behavioural insights and evaluation capabilities to improve strategic communications at both the national and local levels. Aotearoa New Zealand is interested in collaborating further with our fellow member states to continue learning from each other and enhance our capacity and capabilities in communicating future health responses. Ngā mihi nui, thank you.
Thank you, New Zealand. The next speaker is the Republic of Korea, to be followed by the Cook Islands. The floor is your Republic of Korea.
Thank you, Chair. The Republic of Korea welcomes communication for health approach established in the Western Pacific region. In recognition of the importance of communication, the Korean government has executed similar communication strategy. In response to COVID-19 pandemic, Korea has conducted C4H with basic principles of transparency, rapidness, and accuracy. From the moment we had the first case suspicious of COVID-19 reported, we have continued to announce the information of COVID-19 outbreak, including the number of confirmed cases and countermeasures in a transparent and swift manner. Especially, government officials in charge conducted a daily briefing to promptly disclose accurate information on matters which people have inquiries or need to be explained. Additionally, we've segmented the subject group and provided targeted content when announcing preventive measures against infectious disease, while establishing communication strategy through a regular public awareness survey to combat fake news. We've operated monitoring and science-based measures. Furthermore, we've implemented tools asking public support to overcome health emergencies, such as Thanks to You campaign to express gratitude and sympathy to the public. Such a transparent, speedy, and accurate communication enabled the government to obtain trust and cooperation from the public. Lastly, in order to improve C4H, we would like to propose developing detailed approach considering cultural and social context of each country. In this regard, it would be greatly helpful to have a communication meeting for health emergencies and share C4H strategy and experience with other countries on a regular basis. Thank you.
Thank you, Republic of Korea. The next speaker is Cook Islands, to be followed by Brunei. The floor is your Cook Island.
Thank you, Chair. Your Honor Tato, warm Pacific greetings to everyone this afternoon. COVID-19 forced us to explore all sources and ways how to effectively communicate our plans to prevent and respond to COVID-19 at all levels of our society. Communicating to our people in the wider outer islands, where internet connectivity, radio, and television access continue to be a significant challenge. Miscommunications on vaccination became a major issue for our health team to deliver accurate information related to COVID vaccines. However, we found ways to pull through by the collective effort of personal networks, national coordination, and collaboration. I take this time to thank WHO for coming on board to donate key telemedicine equipment late last year. We have now installed these systems on all 13 inhabited islands of the Cook Islands. In order for this work to work effectively in this system, my government supported this project to work effectively by funding the installation of satellite dishes to enhance and ensure guaranteed internet connectivity to all medical centers on these 13 islands. These systems were installed and completed in a timely manner just before the first COVID case was detected in the Cook Islands. Communication for health in all areas of health response play a major role in influencing our human behaviors. Social media has become an integral part of our lives, especially for young people. So we must take this opportunity to take advantage by strategizing our collective approach using technology to create effective communications. The management of NCD, mental health, cancer, smoking, and other medical conditions affecting our people are just some of the areas that will require significant support for a better health outcome for our region. I thank WHO and the Secretary for coordinating this work and look forward to advancing this work to improve our health communications widely within the Pacific region and at the national level to achieve goals that set out, making the Western Pacific the healthiest and safest region in the world. Thank you, Mr. Chairman.
Thank you, Cook Island. The next speaker is Brunei, to be followed by Samoa. The floor is your Brunei.
Thank you. Brunei Darussalam applauds and supports the initiatives of the Western Pacific Region Office for highlighting the Communication for Health agenda. Brunei Darussalam is also committed on using the Communication for Health approach, which was evident in our response during the COVID-19 pandemic. To tackle infodemic during the COVID-19 pandemic and ensuring a successful national vaccination program for COVID-19, Brunei Darussalam worked closely with WHO's Region Office for the Western Pacific in the implementation of the Strategic Risk Communications and Community Engagement (RCCE) activities. Our commitment is also reflected in establishing of a Behavioral Insights Unit within the Ministry of Health, where a roadmap has been drafted with the help of WIPRO. With the establishment of this unit, the Ministry of Health will design and implement policies, programs, and public health interventions that are grounded in evidence by understanding people's behaviors, which will subsequently support the delivery of effective health programs and services, as well as positively change behaviors. Towards this, Brunei Darussalam supports Malaysia proposed resolution on behavior science for better health at the upcoming 152nd session of the Executive Board and the 76th WHA. Strategic health communication is indeed important to promote positive changes in attitudes and behaviors. The Ministry of Health, through the Health Promotion Center, has continuously implemented awareness programs and activities to address the threat of NCDs, which is unfortunately rising in the country. In a recent initiative, the Ministry of Health has successfully launched a nationwide health promotion campaign called BN on the Move with the use of the Brew Health mobile application. This campaign aims to promote a healthy lifestyle through walking or increasing physical activity through a steps challenge. That is the 1 billion steps challenge, which was a success, whereas a nation collectively was achieved within 8 days. We are now in the midst of a new challenge, which is 20 billion steps. Lastly, Brunei Darussalam commends the WHO for its effort in establishing the Communication for Health approach, as well as the continuous support from WHO to Brunei Darussalam and member states for the guidance on using this approach to deliver positive public health outcomes and intervention. Thank you, Mr. Chair.
Thank you, Brunei. The next speaker is Samoa. To be followed by Vietnam. The floor is yours, Samoa.
Thank you, Chair. Samoa remains committed to delivering effective public health outcomes. The COVID pandemic has demonstrated the crucial role that communication for health plays through the dissemination of correct health information at all levels of society. We recognize the need to continue to connect with audiences through powerful stories and the importance of multi-sectorial collaboration. Access to accurate health information is crucial for preventive health measures, and especially during disease outbreaks, as we have recently experienced. This new digital age has changed the communication landscape, where a high percentage of the country population have gained access to the internet through mobile phones. Foremost in this area is to better understand the best possible way to utilize communication for health to ensure that there is a continuous flow of accurate and reliable health information and at the same time address the challenges of misinformation online. For Samoa, we have given importance to communication for health. It was because of our recent experience with the pandemic that we have invested our time in prioritizing communications for health. Samoa has furthermore received technical assistance from WHO and UNICEF in the development of Samoa's risk communication strategy, which includes the handling of sensitive health information. It is vital that communication through community engagement reaches the vulnerable population in a timely manner. We firmly believe that if people are well informed, then informed decisions will be made. Mr. Chairman, we also remain concerned by the growing misinformation pertaining to health that circulates on social media during outbreaks, which can be misleading to the general public. This challenge we have addressed through advocating that the information on the Ministry of Health government website and linkages to credible websites such as WHO and CDC, to name a few, contains the correct information. In summary, we continue to believe that communication for health is a crucial area and is also the cornerstone of our people receiving correct information to enable well-informed choices and efficient access to care and treatment. Thank you.
Thank you, Samoa. The next speaker is Vietnam, to be followed by Papua New Guinea. The floor is yours, Vietnam.
Yeah. Thank you. Firstly, Vietnam would like to thank regional WHO for giving us opportunity to share our experience on communication for health in the process to achieve health system health outcomes. It is a good chance for us to exchange knowledge and learn from other countries to scaling up the use of communication for health in the Western Pacific region. Communication plays important roles in strengthening healthcare systems. It is critical to understand populations' communicating needs in healthcare and barriers to communication in healthcare to be able to design a strategic communication for better healthcare. Healthcare systems are facing with many challenges from people's perspectives. First, people have higher healthcare needs and higher expectations in healthcare. Second, changing in mobility patterns in which increasing NCD. Third, people lack of information and knowledge on health, so they are not able to manage their own health. Implementing people-centered healthcare, we need to concern their knowledge, attitude, and behavior. Being aware of the important roles of communication in healthcare, Vietnam has used communication as an effective tool for advocating people's behavior change to reduce risk factors of health, as well as promoting better community engagement in healthcare. During the COVID-19 pandemic, Vietnam has implemented effective public communication campaigns and transparency. Vietnam prepared a good public communication strategy for preventing COVID-19. What also helped the country beat back the virus was a timely public information focused on the disease, transparent and tailored information to the community to improve people's awareness and understanding on the importance of their responsibility in preventing COVID-19. Various types of information were provided to the community, including how COVID-19 is transmitted and how to prevent its transmission, recognition of the symptoms, self-reporting on health status, protocol when suspecting infection, quarantine method, etc. The Ministry of Health of Vietnam updated information on COVID-19 every day through various channels, such as sending text messages to individuals, internet, or mass media. Various types of communication and declaration method was used to guide pupils to good practice. This includes songs, pictures, advertisements, and movies, which are easy to understand and remember. In the community, this improves trust of population to the government and lead to their compliance in implementation. So Vietnam expects to learn best practice from country members on communication for health and to receive guidance from regional WHO on development of a strategic communication for behavior change to achieve greater impact of healthcare and improve people's health and save lives. Thank you.
Thank you, Vietnam. So the next speaker is Papua New Guinea, to be followed by Guam, United States of America. The floor is your Papua New Guinea.
Thank you, Chairman, for this opportunity. I'd like to take this opportunity on behalf of the Ministry of Health and Department of Health to thank you and Deputy Chair for the proceedings of our meeting so far. I also would like to extend our thank you to our Director General for his presence with us since the beginning of our meeting. And I also would like to pass our gratitude to the Deputy Director General for her leadership so far since she's taken office in our regional office. Thank you, Chair. Papua New Guinea recognizes the importance of the strategic health communications, and the government, through the National Department of Health, is working with WHO and other partners in strengthening the communications for health, component of key public health programs. PNG acknowledges the support of WHO and other friends of PNG for its ongoing technical and financial assistance provided to the health sector and the government in strengthening the national response of COVID-19. Mr. Chair, the health system in PNG, with a population of 9.2 million, is fragile, with fragile health workforce of only about 11,000, was tested to its limit by the COVID-19 pandemic when its first case was brought into the country by a foreign mine worker in March 2020. Since then, PNG has experienced three major surges, two in 2020 from Delta variant and one surge from Omicron in March this year, 2022. As of 20th of October, which is last Thursday, the country has had 45,328 cases, 44,556 recovered cases, and 668 deaths. Our national vaccination coverage remains at the low due to a significant challenges of misinformation and fake news generated from indiscriminated social media that leaves majority of our population's hesitancies and apathy in the uptake of the COVID-19 vaccines. This is why communication for health remains a paramount to inform the people and the communities with appropriate health promotions message to protect and prevent diseases and injuries to the population. PNG is moving towards integrating COVID-19 into our key public health programs. However, there is still much to do in terms of addressing the ongoing vaccine hesitancy in the country. In line with this, the Department of Health is developing a communication for health strategy, and its implementations will be done through an oversight of the health promotions and education branch of the Public Health Division. Mr. Chair, the communication for health strategy will cover an initial 3-year period from 2023 to 2025. The communication for health strategy aligns with the National Health Plan of 2021-2030, and to ensure the people and the community's own health, improve health and well-being, beginning at the community level. The communication for health strategy and rollout of activities will be implemented in phased manner, starting with national level and to selected provincial authorities first, which are the sub-national level. This includes the development of new materials, products, and approaches based on review of revisiting best practices, materials, and actions from the current polio outbreak response that we had a success in 2018 and the current COVID-19 pandemic. These tools will be shared at both the national and sub-national levels for us through network of health promotions officers or communication focal points, frontline health workers, as well as other immunizations and disease control partners, including Christian churches and partners in the country. Mr. Chairman, to integrate the community for health strategy, communication for health strategy, a number of key communication advocacy and social mobilization activities will be designed and undertaken to address issues such as COVID-19, TB, malaria, HIV, AIDS, methanol, child health, and other environmental challenges being faced by the country through a wide range of strategic communication activities. Lessons learned from the risk communication and community engagement strategies through the COVID-19 management will be integrated to our key public health promotion programs. PNG is highly appreciative of the WHO for its continued support in the area and further request further technical support to implement the communication for health strategy, as well as developing communications advocacy, social mobilization, and training strategies for key public health programs. Mr. Chair, the Ministry and the Department of Health will oversee the implementation of the communication for health strategy, request further technical support from WHO to undertake following activities at the national level. As mandated by law, the National Department of Health is responsible government agency to provide the mass population with the most credible and trusted source of information on matters of public health safety and minimize misinformation in the country. B, communication for health component of the COVID-19 and risk communications and community engagement activities will be integrated as a routine activity under the public health divisions. And C, declarations of 2023 as a year of routine immunization. The health promotions and education branch as the most critical public health programs of the Department of Health, and will be charged with development and disseminations of communication messages through the various media platforms in the country. Mr. Chair, the last but not the least, the National Department of Health and Ministry of Health are now embarking on the key communication for health project to review the public website of the National Department of Health of Papua New Guinea. The team will review the website of Communications for Health, Information, Communications, and Technologies for Development, Perspective, and provide communications on how to enhance its software and hardware architecture, design features, and functionality and content to enable effective communications of the work of the Ministry and Department of Health to the relevant audiences. To review, we'll also recommend where and what health data can be added on the website. In addition to information technology, the governance arrangement on how to maintain, update, and evaluate the website regularly. The Ministry and Department of Health requests support, technical support, and financial support from the WHO to implement this vital project going forward. I thank you, Chair.
Thank you, Papua New Guinea. The next speaker is Guam, to be followed by United States of America. The floor is your Guam.
Thank you, Honorable Chair, and thanks to the panel's presentation. It was really wonderful to see the best practices. The United States territories represented, I'm representing American Samoa, CNMI, and Guam, USA. So I want to say Hafaday, Tiro, and Talofa. The United States territories strongly support the goal of building capacity and experience in the application of C4H and support member states as we scale up the use of C4H and through joint efforts, better health outcomes are contributed. We need to keep pace with the increasing popularity of social media tools that have been providing misinformation about science-based methods to address the public's health. What has worked with the territories is similar to the panel's presentation of using the localization of information by using community members and leaders. People our communities trust in pushing the public health message. We all have a story to tell, and supporting member states in the delivery of these stories is essential to improving the health outcomes of our people. From our community leaders that provide authoritative and evidence-based messaging to community members that provide peer and experienced ones. Timely and thoughtful perspectives are essential in delivering messages.
During the COVID-19 response, health leaders witnessed the value of localization and putting people at the center of attention, showing that your care was bigger than showing what you know. This was especially useful when, as Pacific Islanders, the acts of social gatherings and family visits were common island behavior. As we proceed with this trajectory for the future towards the healthiest and safest region, the C4H initiative is essential. We must show mutual respect, cultural sensitivity, and acknowledge health behaviors and use sciences to address them. The WHO's vision of identifying strategic communication that applies insights from social behavior and communication sciences to inform and change attitudes and behaviors for improved health outcomes at the individual, community, and societal levels is a huge step in the right direction, especially as we strive to improve primary care, healthcare access, reduce NCDs, mental health, and reach the unreachable. Thank you.
Thank you, Guam. The next speaker is United States of America. The floor is yours.
Thank you, Mr. Chair. The United States really appreciates Wipro's efforts to strengthen health communication capacities, and we welcome this dialogue today. I think we've learned a lot from the speakers sharing their experiences from around the region, and we found it really fascinating to see the different techniques that were used. As we've heard from a number of delegations today, health misinformation and disinformation are serious threats to public health. As we know all too well, the infodemic, including health misinformation and disinformation, has led to negative health consequences, confusion, rejection of certain public health measures, and harassment of public health professionals. Addressing health misinformation and disinformation, as we know, takes a whole of society, multi-sectoral approach, including community engagement and partnership with trusted messengers. The United States welcomes the opportunity to work together to identify misinformation and disinformation, expand research that deepens our understanding of and ability to combat the infodemic, invest in longer-term efforts to build resilience against health misinformation and disinformation, and increase health literacy and trust in public health institutions. And we look forward to continuing to learn from all of you and to continue this conversation in the months to come. Thanks, Mr. Chair.
Thank you. If there are no more delegates who wish to speak, I will now hand over to Dr. Pratt to respond.
Thank you very much, Mr. Chair, and thank you to all member states for your excellent interventions and for your support for this approach. I won't try to respond to each and every intervention, but maybe just draw out a couple of the key themes that I heard and the requests for support that you asked of us. So first of all, on the themes, I think in different ways you all touched on how COVID has shown us the importance of good public health communications, and now feels like the time to seize on that awareness and really scale up the C4H approach to a broader range of health issues that many of you touched on. Another theme about the importance of transparency, speed, accuracy, especially in emergency communications. The Republic of Korea delegate made that point very strongly, and that's of course a fundamental principle of the C4H approach, as well as the importance of the use of multiple channels, depending on the context, depending on the audience we're trying to reach. Philippines, New Zealand, Japan, Vietnam all made the point that we need to be adapting the different channels that we use based on context, issue, audience. Several of you, I think, spoke very powerfully to the importance of using trusted spokespeople, whether it be faith-based leaders, community leaders, doctors, healthcare workers, as well as the importance of empathy in that communication. I really like your line, Esther, that showing that you care is just as important as showing what you know. I'm taking careful note of that one. Again, I think many of you touched on the importance of that, the Solomon Islands, New Zealand, the Philippines, the American territories. So thank you for emphasizing that very important point. Importance of communication being informed by the communities that we're trying to reach, the communities that we serve, the importance of two-way communication. I think we heard from a lot of member states just now, but also in the panel earlier, that communication is not just about broadcasting information, it's about listening to what people care about, what they need to know, what they're telling us, and adapting our strategies, not just in communication, but in our policy response more broadly. Tackling misinformation and disinformation, of course, we agree fundamentally with the importance of that, and that needs to be a really key focus going forward. Again, something that COVID has taught us, and I thought we heard some really important and powerful examples of that from the Cook Islands, Samoa, PNG, the USA, again. So definitely that will be a key part of the work as we take this forward. So in terms of the sort of requests for support that I heard, but I caveat what I'm about to say with, we've taken careful notes of all of your comments, and we'll make sure we capture those. But some of the themes that I heard, the importance of helping to build capacity to scale up C4H, especially in some of these really important areas that require expertise and skill, behavioral science, behavioral insights. The importance of creating opportunities to share best practice from other countries and from Wipro. I am very conscious that Wipro does not have a monopoly on all knowledge and all best practice in this area. So we feel very strongly that part of that needs to be creating opportunities for you all to learn from each other, not just for us to tell you. So that will definitely be part of the way that we plan to take this forward. And then finally, I heard some of you mention the sort of desire to take forward this approach in your own context and wanting some support for development of your own strategies and approaches. And of course, we would be delighted to assist with that. So I know time is ticking away, Mr. Chair. So with that, I'll turn back to you. But just again, to say thank you very, very much to all member states for your interest and your support. Thank you.
Thank you. We will now resume item 8.1, 8.2, and 8.3. Please press the button to go on to the list of the countries who wish to speak. The next speaker is Australia, to be followed by Malaysia. The floor is yours, Australia.
Thank you, Chair. Australia thanks the Secretariat for its reports on the previous, current and proposed program budget. We support the approach of the revised budget 2022-2023 in taking forward the recommendations of the independent reviews into COVID-19 and note the importance of the new budget in setting the direction of the organisation as we continue implementing the lessons learnt from the COVID-19 pandemic. WHO's program of activities has never been more significant and extensive. We commend the Secretariat for exercising discipline in proposing a zero increase budget for the next biennium. Australia strongly supports the proposed focus on strengthening capacities at the country level through the allocation of increased resources in country offices. This is crucial in supporting member states to build strong and resilient health systems. We note concerns that strategic priority 2 and 3 continues to be the poorest finance segments in both the previous and current budget, which further underscores the importance of sustainable financing in ensuring the WHO is resourced to meet the obligations member states set for it. We echo the comments made by Dr. Jacob in highlighting the importance of our region's support for the sustainable financing decision. Australia commends the Secretariat for its efforts to respond to requests from member states to improve the prioritisation process during the proposed budget development. And we appreciate country-level engagement to enhance the role of member states in setting their priorities. We support the proposed flexibility to enable regions to tailor prioritisation approaches towards their specific contexts, however, emphasise the importance of ensuring consistency in the country-level discussions between WHO and member states, as well as broad alignment across regions to enable transparent prioritisation of activities at the global level. We note that conversations on improving prioritisation are ongoing in the Agile Member State Task Group and look forward to the outcome of these discussions. We are pleased that improvements were made to strengthening of the accountability, compliance and risk management function in the previous and current budget cycles, and that investments on preventing and responding to sexual exploitation, abuse and harassment will be further consolidated in the next budget. We strongly encourage the Secretariat to ensure all levels of the organisation are adequately resourced and equipped to meet their PSEH requirements as set out in the WHO Management Response Plan. Finally, ongoing review and evaluation will be important to monitor the effectiveness of the various new components of the proposed budget, as well as the prioritisation process. And we encourage the Secretariat to continue to engage with Member States on refining these processes. Thank you.
Thank you, Australia. I call on the representative of Malaysia to be followed by China. The floor is yours, Malaysia.
Thank you, Mr. Chair. Malaysia welcomes the Secretariat's comprehensive final report on the program budget performance for 2020 to 2021 and thanks the Secretariat for the update on the program budget 2022 to 2023. We are pleased to note that the increased regional allocation of $403.2 million, which will enable member states to strengthen their country priorities that are aligned with for the future operational shifts and move forward to deliver the vision for a safe, fair, and healthier region. In line with the red box strategy, many of the original activities for program budget 2020 to 2021 were revised to meet the new demands of the pandemic. Malaysia is grateful for the technical support and guidance from WHO in providing technical assistance to support polio response, as this significantly contributed to the closure of the outbreak in 2021. In addition to that, we value the technical support given by WHO to promote policies on healthy diet to mitigate major risk factors of NCDs through the salt reduction program and supporting our national initiative on healthy aging. With reference to agenda item 8.3 on program budget 2024-2025, Malaysia recently participated in the prioritization exercise to outline the list of priority areas, focusing on improving capacities for emergency preparedness and response, strengthening the delivery of high-quality essential healthcare services, and to develop healthcare financing reforms to sustain progress towards the universal health coverage. Ultimately, we want to intensify early prevention initiatives under the enhanced primary healthcare structure to create a more sustainable and resilient healthcare system that adopts a preventive healthcare approach in getting 10 million of Malaysians to be healthy in the next 10 years. Malaysia has also made in-kind contributions to a WHO by supporting the Global Service Center, which is based in Cyberjaya, Malaysia. We will continue to engage with WHO's country office and its partners to address the challenges faced and shape a healthier future for the region. Thank you.
Thank you, Malaysia. I call on the representative of China to be followed by Philippines. The floor is yours, China.
谢谢主席。
Thank you, Chair. China thanks the Secretariat for the report, in particular about the 2024 to 2025 draft budget. The current global situation has brought new challenges to the realization of SDGs. We agree that the 2024 to 2025 program budget should focus on investing the countries, strengthening country capacity and promoting WHO to further provide public goods that can benefit the health of all. China hopes a new approach to setting priorities for program budget can be developed as soon as possible. In the document, the Secretariat proposes to determine priorities through consultation with member states in formulating the 2024 to 2025 program budget. China appreciates this practice. At the same time, we hope the Secretariat will further explain the iterative approach so that member states can better participate. China has noticed that the 2023 to 2024 program budget will increase the share of financing from base budget by 20%. China calls upon member states to increase the flexibility and predictability of the use of voluntary contribution and give the Secretariat greater flexibility in the use and allocation of funds. China believes that this organization should focus on its core business and functions and avoid the excessive and disorderly growth of its business scope and base budget. The connection between resolutions and their implementation costs should be strengthened. It is indispensable to carry out our work within our means, within the resources available to us. It is important for the Secretariat to, based on the consensus of member states, constantly optimize its core functions and internal governance structure and increase the transparency of decision-making and the participation of member states. And at the same time, according to WHA 75.8 decision, any increase in assessed contribution should be accompanied by appropriate governance reforms agreed by member states. It is our hope that in the submitted program budget, there can be necessary explanations for the accompanying reforms. Thank you, Chair.
Thank you, China. I call on the representative of Philippines to be followed by Republic of Korea.
Thank you, Mr. Chair. We thank the Secretariat for the reports on the program budgets for the 3 biennium, and we also thank Australia for leading the Agile Member State Task Group on strengthening World Health Organization budgetary, programmatic, and financing governance. We look forward to greater transparency in terms of prioritization in the budget development processes and priority setting, as well as coordination to facilitate member states' understanding and analysis of program budget utilization for the 2022 to 2023 biennium. This may be strengthened at the country level by considering it as a joint responsibility instead of a sole remit of the Secretariat. We appreciate the Secretariat's work in countries in terms of leading a robust WHO budgeting and prioritization process, ensuring whole of government and whole of society approaches. In particular, we appreciate the effort to achieve synergy in the WHO prioritization process for the 2024 to 2025 program budget and the Philippine government's technical assistance needs mapping with the new health sector strategic thrusts under the new administration. It is through such exercise that member states are able to realize firm positioning in terms of country priorities and country-centeredness. Moreover, accountability entails that member states are given regular opportunities to consider and assess WHO's work in countries through regular country updates on the program budget, as well as avenues that enable proactive feedbacking. This necessitates strengthening the Secretariat's technical capacity to efficiently deliver this role, including the development of digital platforms to enable live monitoring, updating, and feedbacking across time and space. As we try to achieve sustainable financing for WHO, it will be crucial to have alert mechanisms to highlight disparities and pockets of poverty in financing WHO programs. These disparities amount to grave inequities. Thus, such mechanisms should trigger joint Secretariat member state actions to effect necessary and doable adjustments to curtail widening of gaps in health outcomes. Finally, for the extension of the GPW 13 to 2025, it is important that 2024 to 25 program budget features intense focus on expanding health emergencies protection index indicators and methodologies for smaller scale events in order to build local capacities to prevent outbreaks. Moreover, intensifying WHO support in countries for resilient recovery towards the 2030 agenda for SDGs requires tackling the unequal and uneven progress on SDG indicators across populations and countries. Being the last biennium program budget towards the achievement of GPW 13 targets, it is important that this budget enables countries to reverse the backsliding of UHC, reorient health systems towards primary health care, strengthen epidemic and pandemic intelligence, and strengthen the global health architecture. Thank you very much, Mr. Chair.
Thank you, Philippines. I call on the representative of Republic of Korea to be followed by Cambodia. The floor is yours, Republic of Korea.
Thank you, Chair. I would like to convey my sincere gratitude to the Secretariat for preparation of program budget-related report. The Republic of Korea, as the report explains, expects that the process of program budget development is to be more transparent and encouraging participation of member states. I'd like to make some opinions based on the provided report. Firstly, we welcome the proposed approach of a strategic allocation of flexible funding, in particular assessed contribution, which will ensure high priority output without impediment due to earmarked funding. We think this new approach will enhance equity in allocation of resources and resolve pockets of poverty, which is a long-standing issue. Secondly, the proposed 2024-25 program budget shows country-level allocation increase while having a decrease in our regional office. We agree the discretion toward expanding the budget share of country office. However, we are expecting that the future report will contain more concrete information on which category has decreased or increased in allocated budget. Lastly, the report said the final allocation of budget among offices depends on prioritization. We would like to know the criteria for the priority setting following the country level consultation and how priority are decided and reflected at regional level. Providing clear and detailed explanation of the process will be more helpful for member states to understand the budgeting process. Thank you, Chair.
Thank you, Republic of Korea. I call on the representative of Cambodia. The floor is yours, Cambodia.
Thank you, Honorable Chair. Cambodia, we appreciate the WHO support to Cambodia in these bienniums to tackle the variety of health issues, including COVID-19. In Cambodia, the implementation were guided by the vision papers, and funding and the technical support from the WHO is critical, with strong coordination and collaboration between WHO and the Ministries of Health. We noted on the updates on the program budget 2022-2023, as well as 2024 and 2025. In Cambodia, we had a high-level consultation in September this year. We discussed and agreed on a very high-level priorities, and thus 3 thematic priorities and health system strengthening. Based on the ongoing discussion and dialogues between the MOH and the WHO, our common goal in Cambodia is to build 2 careers for safe and healthy Cambodia. We also want to call for more investment in health as a part of social and economic development. We also noted that it is important that the lesson learned from COVID-19, as well as emerging public health, should be reflected in the final budget. Finally, Cambodia is fully committed to work with the WHO and member states toward the vision for the future, a safer and healthier Western Pacific region. I thank Honorable Chair.
Thank you, Cambodia. Are there any more representatives who wish to speak on this topic? Japan, the floor is yours.
Thank you, Chair. Japan appreciates the UPRO Secretariat for the report of budget performance update and proposal of the program budget 2024 to 2025. Japan also welcomed the Secretariat's effort of engaging member states for improving transparency in the development and the implementation of the budget. We have 2 points to deliver on the financing outlook of the program budget 2024 to 2025. First, it was agreed that the Secretariat develop the budget proposal with an initial increase of 20% of the assessed contribution. It is also our understanding that the 20% increase in assets contribution will be accompanied by increased budget transparency and the discussion of a 20% increase will be made at the executive board meeting and the WHA in 2023. Japan hopes for an opportunity that member states would be briefed on the outcomes of the headquarters prioritization as well as the UPRO Secretariat presented. We consider that discussion among member states, including PBAC and the EB next January, will also be built on these outcomes. Second, on projected financing for the proposed program budget 2024 to 2025, we are concerned about whether UPRO's overall revenue will be affected or not. We would like to pay attention to the impact that UPRO may face due to the increment of asset contribution and the potential reduction of voluntary contribution. I thank you.
Thank you, Japan. May I call on the representative of New Zealand. The floor is yours.
Thank you, Chair. Tēnā koutou katoa. Aotearoa New Zealand thanks the Secretariat for its presentation on the program budget development for 2024-2025. We fully support the priorities of the 13th General Programme of Work as outlined by Director General earlier and before the future plan. At such a pivotal time in global health, it's crucial to target our investments. We must promote health and well-being, strengthen primary healthcare and our systems for pandemic preparedness and response, and harness collectively the power of science and innovation. Importantly, we must all continue to strengthen the WHO as the leading authority on global health. We would like to highlight the Secretariat's note in the report that for every $1 invested in the WHO, there is a 35% resulting return. Colleagues, this is why the decisions reached at WHA 75 in relation to sustainable financing, including the proposed incremental increase in assessed contributions, are so important. If the WHO is sustainably and flexibly funded, it will continue to deliver on the full breadth of its mandate that will see results for us all. We appreciate the Secretariat's efforts to strengthen transparency and accountability in the program budget development process, including steps taken to strengthen member states' understanding of the process as a whole. Thank you. We are also pleased with the Secretariat's focus on incorporating the lessons learned from COVID-19 into the program budget development, as well as the increased emphasis on strengthening in-country capacity. Implementing a more effective and targeted budget prioritization process at the country, regional, and global levels is key to implementing the 13th GPW's unfinished business and ensuring WHO can best deliver on its member states' needs and priorities. Chair, Aotearoa New Zealand retains a strong interest in the implementation of effective policies for the prevention of sexual exploitation, abuse, and harassment within the WHO. As a result, we hope to see that all 3 levels of the organisation will be adequately resourced to meet their PSEAH requirements as set out in the WHO Management Response Plan. We look forward to engaging in further member state consultations on the budget ahead of the 37th session of the PBAC and 152nd Executive Board meeting next January. Similarly, we are committed to the work underway in the Agile Member States Task Group on strengthening WHO's budgetary, programmatic and financing governance and acknowledge our Trans-Tasman friends Australia for their leadership of this process as co-facilitator. Ngā mihi nui.
Thank you, New Zealand. May I now call on the Secretariat to respond to the points that have been made.
Thank you, Mr. Chair. Good afternoon, everyone. Unfortunately, Dr. Capuano got called away, so I'm going to go ahead and take in the comments and try to respond on the regional issues that you raised. And we have our colleague again, Jana Rieseger from HQ, who will take some of the issues you raised about the global process. I mean, first of all, thank you so much for all the rich inputs to this discussion. Your comments can really help us improve our processes and leading up to our 24-25 budget build and best support the member states on the way. I think what we're hearing is thanks to us, but it's really thanks to you all for working through all of the governing body meetings and the processes to allow for WHO to have the opportunity for more sustainable financing, for working with us right now, especially on the prioritization process in the country offices. And I appreciate Delegate from Cambodia highlighting a bit of what has been done there. I think it's important, and it was requested by a number of delegations for us to describe a bit how it's going, and I think that Cambodia is one example. Some specific responses. First, I'd like to talk about the mention of the prevention of sexual exploitation, abuse, and harassment. Thank you very much. The resources that are being provided are substantial now, and I can report that in the region, we were able to hire a management officer in this area who's been very active since she joined us in July, has visited a number of countries, is working closely with the global network, developing tools to manage risk. And I believe on Friday during the WHO reforms discussion and Agenda 16, she'll be able to update you. But I can confirm to those who mentioned this that we're being well supported funding-wise for this important task. It's just starting, and you know, we're on a path to improve in this area. Also, I think we heard a lot about the importance of aligning the budget with both the GPW 13 and the For the Future vision. Thank you very much. I think this is your work that we're trying to reflect. So it's great to get the inputs from you on this to make sure we're on track. And that also feeds into the prioritization discussions that are ongoing now in the country offices. And also welcome from you all, but from us as well, that we are really looking to improve and increase resources in our country offices to support you better. And I would also like to take advantage of the comment made by a delegate from Malaysia, and thank you very much for the continued support in kind of hosting our global service center. Even though it's a global function, we all benefit from that, and we appreciate very much that contribution. A little bit on transparency and accountability. We do have a program budget web portal that offers monthly updates in terms of country level implementation at the level of the GPW 13 outputs and by expenditure type. The program budget web portal bridges programmatic delivery, results, and financial information over the course of a given biennium. It's updated monthly since January 2022, and based on the discussions you had at the global governing body meetings, was increased from quarterly to monthly. It does offer detailed funding and implementation information at geographic, programmatic, and contributor levels.
and it supports the integration of our contributor outreach and strategic resource requirements in terms of allocation. It also offers dedicated contributors section for certain type of contributions. So there's a lot of information out there on the web portal, again, in line with our desire and your desire for increased transparency and accountability. We heard as well about trying to tackle the chronic pockets of poverty in our processes. We're using tools such as monthly heat maps, and those also will be integrated into the program budget web portal soon, monitoring the overall financing by global outcomes, which will help address the pockets of poverty. Moreover, the creation of the Resource Allocation Committee also looks at ensuring more equitable financing using an inclusive approach. And those of you who called for more flexible financing, this is really where the decisions get made to make sure those pockets of poverty are dealt with. And the regional offices actually meet on a regular basis to discuss this with DDG, who leads this effort globally. Under financing, we tackle with increased sustainability, predictability, and flexible financing to enable the organization to fully deliver on its mandate. And we thank you for that, because that's what's happening now. On the PB 24-25, we will fully integrate and align with the 5 priorities as stated by DG back in January 2022, aiming at meeting the triple billion targets by 2025. And from a regional perspective, the country prioritization process is really showing great alignment, not only with the GPW 13, but also with the For the Future vision. And it has a high level of continuity with what we're doing in 22-23. Further on the country prioritization process, so we basically started in September, October. We've been consulting with you all to identify programmatic country priorities. During these consultations, a robust prioritization exercise is conducted to identify the top country priorities, requiring technical support from WHO under the umbrella of both the For the Future vision and aligned with GPW outcomes and outputs. The consultations focus on the what and how, trying to define high-level deliverables the Secretary would work on during the biennium. The process has been guided by global and regional strategic directions, as well as available data, evidence, and trends, especially at the country level. And it is focused on those areas where WHO's added value is recognized. We are taking an iterative approach to best delineate and refine country priorities and drive impact at the country level. This approach, while tailored to the individual country context, means that prioritization happens through a set of interactions and engagement during the timeline of the process. Regular interaction catered to the needs of the individual countries represent the best practice in agreeing on high level and attainable deliverables within a biennial timeframe. I think, Chair, I would stop here. Apologies if I missed anything, but just to summarize, we really appreciate your inputs. It's really timely to get your inputs, and we'll definitely take them into consideration as we move forward on the 24-25 creation of the program budget. So, Chair, if it's okay, I would like to hand over to our colleague in HQ, Yana, to answer any global issues that were raised. Yana, over to you.
Thank you so much, Jeff, and thank you very much, member states, for very rich comments. They're greatly appreciated, and it's precisely what we were hoping to hear the regional committees, your reflections on the priorities and on the process. It is good to hear that we seem to be on a good track. And many of you spoke that you appreciate the strengthening prioritization process. Thank you much, Republic of Korea, specifically talking about the allocation of flexible funds to the priority output. So it's good to hear that this approach is supported. more specific comments to Australia, I'd like to pick up also your comment on the PRSCH and transparency and accountability, just to assure you that the 50 million increase of the program budget, which was approved by the member states in May this year for PRSCH and transparency and accountability, will go forward and will be preserved in the budget 24-25 in order to make those actions and results sustainable. So you will see the same sort of narrative around this as in the revised version and going forward into 24-25. On the iterative approach of priority setting, and Jeff spoke about it as well, I will just add to it also from the global perspective, and several member states asked the same question on maybe slightly different variation on how this will be reflected at the regional office level and at headquarters level. There are two, I see it as a two sort of ways iterative approach. One is internally between the three levels, and another one is externally between the Secretariat and the member states. If I take from the Secretariat and member states, so on the 17th of November, we have the special session of the Program Budget and Administration Committee, where we will specifically focus on the results of a prioritization. So we will show whatever we have up to that point in time, because all the regions are still consolidating their prioritization results. And we would like to hear member states' reflections on whether the priorities reflect the reality, whether this is really a good direction of travel for the program budget 24-25 development. There will be further briefing as well with the member or consultation with the member states towards the end of November, where we will pick it up again. So we will have this regular touch points with the member states to provide to you where what we have, where we stand, and hear back from you whether this is the right approach, this is the right direction, and then take it back home and continuously work on the program budget development until we bring it to you for the executive board, and then further developing it for WHO. Internally, the country priority settings, as Jeff was just explaining, will of course be taken up at the regional office level, and they will influence the regional office level priorities and the budget narrative. The same is for the global level. So for headquarters specifically, so we are starting the process of prioritization at the headquarters level. And we're looking at the several components where headquarters plays a very strong role. One of those being global public health goods. And global public health goods have to respond to country priorities as well. So we will bring the country priorities to the process of global public health goods discussion and see how through global public health goods we can best respond to the country priorities. The same for the technical assistance that's provided from headquarters level. So whether this assistance is required and needed according to priorities will be prioritized and planned in headquarters. So this is the iterative process inside the Secretariat, inside the organization, which is ongoing, which will pick up more pace as the global level comes in, because the country priorities are now available, and it will continue through the program budget development and into the operational planning after the program budget approval. So another, also the Republic of Korea asked the question about having a better understanding on the priority setting and the budgetary processes and the iterative approach. So one of the explainers that we will be preparing to accompany program budget 24-25 will be specifically on the prioritization process. where we also envisaged 6 separate chapters where every region could bring in their flavor and specificity to the priority setting, so that it is available for review and understanding of all member states when they come together for the decision on the program budget. The question on the assessed contributions on 20%. I just wanted to, of course, reiterate that everybody will benefit from the 20% increase. Every regional office, of course, and the country office. So we will, through supporting the high priority outputs or committing to a certain level of funding of those outputs, we will, of course, keep the countries in focus. So we will be looking at the countries first, at the regions next, and so at the headquarters or global level as a sort of a third step to it. So country impact and focus will really be the theme of building budget on priorities, but also as we implement the budget on how we finance it and how we implement the budget. Also the question, the last one I will address of Republic of China, where you are asking about the necessary explanations in the program budget 24-25 on the budgetary reforms that should accompany specifically the increase of asset contributions. We've seized the opportunity with the program budget 24-25 to start implementing what we've already heard from you as the ask for development of program budget. But of course, the work of the Agile Member States Task Group is ongoing, and it will have its report to Executive Board, and we will be then taking more and more of what is being agreed and decided into the program budget development 24-25. But we'll continue this because this is not just one budget bound. So we will, of course, continue implementing the reform, the agreed reforms in the subsequent budgets as well. Thank you.
Thank you, Mr. Kopsas and colleagues. If there are no further comments, the committee notes the program budget 2020 to 2021 final report, program budget 2022 to 2023 update, and the inputs for the program budget 2024 to 2025. We have run out of time today to start item 12, non-communicable diseases. So we will start item 12 after tomorrow first session, item 16.2, WHO work in countries. I thank you very much. We have now reached to the end of today's session. We will reconvene tomorrow at 9 a.m. in the morning, Manila time. I would like to invite the Director of Administration and Finance, Mr. Kopsa, to remind us of the details. Thank you very much and see you tomorrow.
Thank you, Chair. I'll be quick. Just an update. Be quick when it's on. There you go. I'll be quick. Just a reminder, the daily journal is now available on our website and through the app. If any corrections are needed, please note them and submit them to the inquiry desk. There's a rapporteurs meeting again at 5:15 tonight, so directly after this, and that's again in the second floor, the Amethyst room. If you go up the stairs to the second floor, you take a right, it's the room at the end. Just a reminder as well to please leave your wireless receivers and headsets in the room at the conclusion of each session. That's all, Chair. Thank you very much.
Thank you very much.